Can I get started? Okay, here we go. Okay, so welcome. I'm so grateful that you guys are joining me for this PCOS workshop. I've wanted to run this group for a really, really, really long time. And here it comes to fruition. We have 60 women at least who are joining live. And I'm really, really so excited that you guys are all participating. I want to introduce myself first because a lot of you guys who are joining know me personally, either professionally because you've worked with me or because you are my friends and you care and you want to know more about female hormones and PCOS. But just in case you don't know who I am a functional nutritionist, Neely Grootman, and I received my degree in biochemical and nutritional sciences from UC Davis, or University of California, Davis, which is one of, I think, the best nutrition schools in the United States. I didn't go there for that reason. I was very lucky that that's just how it worked out. I was really honored to grow up in a household that really valued health and the way we live and the way we practice eating. And when I was in college, I had to decide what I was going to do. I really loved food. I really love people. I really love science. And I decided, the best integration of all of those 3 points is nutrition. So I tried nutrition. I took the medical route. I was thought that I'd be either a nutrition researcher or a doctor. And I was pre-med for a really long time and then found that doctors don't really have a relationship with their patients. And that really bothered me. I really wanted to be able to have a connection with those who came to seek my advice. And so therefore, I decided to become a functional nutritionist instead. I knew that I would have a more intimate role with my clients and I would be able to make a bigger impact, in my opinion. So here I am 13 years later, after starting my clinic in 2011. I have a very dynamic approach when it comes to health. Just a little bit about it. The way that I view the human body in regards to health is that it's 12 physiological systems that really need to be put in alignment with one another. And our perception of disease is really the lack of balance between these 12 systems. And when people come to me in my clinic, what I essentially am trying to do is figure out which of these 12 systems are not in alignment, meaning like the endocrine dysfunction is this much off, and the digestive dysfunction is this much in this direction, and that all collectively makes a picture. And so then my role is to help a person with natural practices create alignment in their life and in their body. So I decided recently that I was going to switch gears and work predominantly in women's health. Even though it's something that I've been doing for the last 13 years, I said, okay, this is going to be a really major focus for me. I feel like the female population is really underserved, both in hormonal health and in digestive health and in mental health, but we're going to focus more on hormonal health today. But this is going to be my new mission. I'm going to help women get better served in healthcare. And so that leads to this topic. Why did I decide to put together a whole workshop discussing PCOS? Okay, so here we go. As I said before, women in the healthcare system are underserved. What medications a woman needs to even be on, what reactions. Let me actually say this a little bit differently. The medical system is geared towards men and male healing. Medications are tested on the male metabolism, not on the female metabolism. When studies are made for nutrition and herbs, most of it is done on men, not in the sense that they are the only populace, but we are the amount of women that are actually in research is nowhere near the amount that the male body is studied. And so there's a lot of information as of late that has come out that honors women and honors women's health, but it's not yet integrated. It's not yet integrated into the current mainstream medical field. So when you go to your doctor, for example, and you guys discover that there's PCOS, it's a question mark whether or not he's going to put you or she's going to put you on the birth control medication that is most appropriate for decreasing androgens. That's an example of how PCOS, just as a small women's health issue, is not yet integrated. There's a way of diagnosing it. There's kind of a concept of how are we going to treat it, but the treatment plan itself isn't necessarily ironed out for most medical professionals. Okay. So because of this fact that women are being underserved in mainstream medical system, that is why I decided to make this workshop. So let's talk about some facts. PCOS, which stands for Polycystic Ovarian Syndrome, affects 1 out of every 10 women. Okay? That's an average. It could be anywhere from 8 to 13% of a given population worldwide. And depending on what country you're in, it's either going to be slightly less or slightly greater. However, 70% of women who are affected have no idea that they have PCOS. So that means that there are people who are walking around with the symptoms of PCOS, are not successfully ovulating, have infertility issues, and don't even know that that is the condition that they're walking around with. And that's very silly because there's a very clear treatment plan that they could follow and their life would be tremendously better. Okay. Another issue that really bothers me is that PCOS has become like this catch-all term for anyone with a hormonal imbalance, right? So you could have a woman, maybe she perhaps even has estrogen dominance, maybe she suffers from low progesterone, something unrelated to PCOS, but because it's not going to be well tested or even probably addressed by her doctor, she's given the label of PCOS, which has become just an umbrella term for you have a hormonal imbalance. And she is remain untreated, nor is she any closer to figuring out what her hormonal issue. So one of the things that we're going to talk about, the katan, in a very small form, is what are some other hormonal issues that can happen to a person that sometimes is labeled as PCOS, but is not actually PCOS. Okay. And then again, like I said before, I hinted at before, there are long-term permanent treatment plans for PCOS, but it's simply not available or has not yet acclimated into the mainstream medical system, right? There are proven herbal remedies and proven diet protocols that help with either the androgen dominance that occurs with PCOS or the insulin resistance. But your doctor, who only sees you for 15 minutes and doesn't even review your blood work with you normally, isn't going to be giving you that advice. Normally what happens is your doctor just prescribes you birth control. And although that does put a pause on some of the symptoms, it doesn't actually cure the PCOS. And it's important to remember that PCOS does have a cure. Okay, so that was the whole impetus for this workshop. I felt like women were being really underserved, and I wanted to make sure that they were served. It's important that women know their bodies, women understand what their hormonal cycle is, and know when to test for it. They need to be able to feel empowered to be their best health advocate. Okay. So let's talk about what the goal of today is. This is what I want to make sure that you walk away with, okay? Regardless of whether or not you have PCOS, or maybe you suspect that you have some type of undiagnosed hormonal imbalance, or maybe you're a mother, or maybe you're someone who's a practitioner. So regardless of who you are, what I want you to walk away with is a firm understanding of the pathology of PCOS. Like, what is it physically? What is it chemically? What is happening in the body when someone legitimately has PCOS? All right. Then I want you to understand what the signs of PCOS are, because it could be that you're one out of 10, and you're one of the 70% that don't know that they have it, and maybe they do. And then most importantly, most importantly, is to identify what the 4 root causes of PCOS are and to understand them. And the key word is to understand. If you understand what the 4 root causes of PCOS are, you'll not only understand PCOS, but you'll also further understand any other hormonal imbalance that can happen. And then most importantly, have practical solutions for each root cause. So it's important that you go away from this lecture feeling really empowered, but it needs to be practical. You need to know, okay, I just got all of this information that was really wonderful, great, now what do I do? So leaving this lecture with a firm understanding, I watched this regardless of my situation, and this is what I'm taking away from this. This is what I'm going to be doing tomorrow, a week from now, a month from now, etc. And then part of that is knowing how to properly test your hormones, because I am not a mind reader. I don't think you have X-ray vision, and I don't think your doctor has X-ray vision either. So there's no way of you knowing what your hormonal condition is unless you test it. So if you walk to your doctor and you don't know what test you should be asking for, then you're at his or her mercy. And again, because PCOS and most hormonal conditions are not part of the mainstream community in the medical system, you're not going to be properly advised. I see it very often. So those are the goals of this masterclass. They are nice goals. I want you to take something to heart, that the information that I'm going to share with you today is actually ridiculously simple. Now, if you're someone who's not used to this type of information, it might sound really sciencey, and that might just like alert alarm bells in your brains, like, oh my gosh, I'm hearing words that I've never heard before. I don't know what that means. I'm telling you that everything I am teaching you today is simple. And I'm so happy to repeat something over and over again if I'm not making myself clear. Because if something doesn't sound simple, then maybe it's my fault that I'm not saying something in a simple way. So I urge you to interrupt me, ask a question, and I'm happy to re-speak. Okay, cool? All right. So let's first talk about what PCOS is. Any questions so far, actually, before I start? We're okay? Okay. So what is PCOS? So first off, PCOS stands for Polycystic Ovarian Syndrome. What that looks like is an ovary that has a lot of cysts on it. We're going to discover that they're not really cysts. So what happens in a normal feminine cycle, when a woman menstruates, then ovulates, etc., is that during that time, an egg is supposed to mature and then be released if ovulation occurs. What happens is, in a condition or in a woman with PCOS, the follicles that become the egg do not fully mature. And so these immature follicles that were supposed to be eggs that were going to be released actually had, and I mean this literally, a retarded form of ovulation, or an incomplete form of ovulation. And that incomplete ovulation will become larger and bubble up and look like a cyst. Okay, and so when we say polycystic ovarian syndrome, we don't mean that there are actual cysts on the ovaries. There are a bunch of underdeveloped follicles that then appear to look like cysts. So if someone were to say to you, like, let's say, God forbid, you went to a doctor, you had an ultrasound, and he said, oh, you have a cyst on your ovary, that does not mean PCOS. Okay? If you had an ultrasound with your doctor and your doctor said, oh, by the way, I see a lot of different follicles on your ovary, that is a sign of PCOS. And what they're traditionally supposed to do is count the number of follicles that they see on your ovary. So I'm a very visual person. So let's actually see what this looks like, okay? In the development of your follicles, every person is born, every woman, I should say, is born with primordial follicles. These are the little eggs, the little baby eggs that you are going to eventually one day develop into primary follicles. And then with the stimulation of your hormones, they become secondary follicles. And then there's a type of ovulation process that occurs with increasing amounts of FSH, follicular stimulating hormone, and LH, which stands for luteinizing hormone. And then eventually ovulation occurs, and this little tiny egg is released, okay? So where does it deviate for someone with PCOS? So what happens is with PCOS is there's a failure for this ovulation step. When we go from the secondary follicle to what's supposed to be the follicle that released the egg, this in-between step is what stops, okay? So then what tends to happen in this polycystic ovary is that you have a bunch of these swollen, underdeveloped follicles. And that's what looks like cysts, but is not a real cyst. Okay. And there's a problem with this because you secrete luteinizing hormone to create this ovulation process, but because the egg never fully matures, or the follicle never fully matures and then releases the egg, it disrupts the luteinizing hormone feedback loop, and luteinizing hormone continues to increase and increase and increase. So if a woman was to be properly tested for PCOS, one of the key things that they would test for is luteinizing hormone. And if it was really elevated, that would be a clear sign of PCOS. Okay, not always, because we're going to see that there are multiple things that we want to test for when it comes to PCOS, but high luteinizing hormone is one of them. And why does that happen? Because the feedback loop is disrupted when the egg doesn't fully mature. Did that make sense so far, or was that too sciencey and was that confusing? Was there anyone who needs me to repeat it? Because I'm very happy to. You'll see I'm very patient. I'm happy to repeat myself like 5,000 times. Going once? Going twice? No? Okay. So let's continue on. So we understand what PCOS is, right? PCOS classically is when you have an incomplete ovulation. That is what it is. An incomplete ovulation. Over and over again. And you have the appearance of retarded, or what do I want to say, underdeveloped follicles. Okay. Women tend to ovulate between 8 to 9 times a year. Not every month. Even if they have a beautiful, consistent cycle, they do not necessarily ovulate each time. So just because you didn't ovulate one time doesn't necessarily mean you have PCOS. There could be many reasons why one time or even 2 times you didn't ovulate. But not every time you do not ovulate do you have the appearance of what you would see in a polycystic ovary. Does that make sense? Yeah? All right. So now that we understand what PCOS pathologically looks like, okay, now let's talk about the signs. How do you know just externally or internally if you have PCOS? So first off, because you don't have successful ovulation and because the luteinizing hormone is going to be really high, you don't have the proper hormonal feedback loop. Like as we're going to see very soon, your hormones work in a domino effect. And because the hormones are very scattered and not communicating well with one another, your cycles are going to be off. So they could either be too short or most likely too long, okay? Or you most likely won't have any periods at all. Like it's very normal for women with PCOS not to have their period every 3 months, every 6 months, once a year, which also makes testing really difficult because like if you're supposed to test your hormones on day 2, then you could be waiting months until you do that. Okay, so that's number one. And then there's hirsutism, which is excessive hair growth. So this is not hair growth on your head. We would all love that, but it's hair growth on your face or on your chest, anywhere where you would typically see hair grow on a man. Acne, scalp hair thinning, weight gain, insulin resistance, darkening of the skin. So that could be behind the neck, on the creases of the elbows, under your breasts and your armpits. Infertility, which obviously makes sense because if you're not having a successful ovulation, like how are you going to get pregnant in that situation? Obviously, polycystic ovaries, you're going to see enlarged ovaries with many small follicles. Again, you're normally going to see follicles that are underdeveloped on an ovary. The question is, how many do you see? Are you seeing 2 or 3, or are you seeing 10? If you're seeing 2 or 3, that is not PCOS. If you're seeing 10, that is PCOS. Okay? And then mood disorders. If your hormones are all over the place, if your estrogen is too low, if your progesterone is too low, then you are not going to be a happy woman. You're going to be miserable. Typically, you're miserable and you just don't know it because you're so used to your normal condition. Okay, so these are the signs of PCOS. Now, irregular periods, facial hair, acne, those could be signs of other hormonal imbalances. They're not necessarily just for PCOS. But again, I'm going to say this. PCOS has become an umbrella term. A lot of people, a lot of women with hormonal imbalances are labeled with PCOS when they don't really have it. So the clear sign that you're looking for are these polycystic ovaries. And the only way that you can do that, the only way that you can assess that is if you do an ultrasound. If you don't do an ultrasound, there's no way of knowing if you have PCOS. You could see that you have insulin resistance. You could see that you have androgen dominance. Those are all things that you could verify in a blood test, but that doesn't necessarily mean that you're not successfully ovulating. You could have those conditions and not have PCOS. Okay, makes sense? Okay, so now that, again, we understand this is what PCOS, this is the pathology, and I understand what the signs are. Now let's address the 4 root causes. And this was really important for me because I get a lot of clients that come to me and they say that they have PCOS and they either think that it's just insulin related or that it's just androgen related. And there are actually different reasons for PCOS, and they're even more nuanced than that. Like, okay, so you have androgen excess, but like, where are those androgens coming from? Because where they're coming from is going to change the treatment plan. Okay. All right. So let's take a pause. Let's summarize. There are how many causes of PCOS? At least 4. At least 4. Androgen excess, insulin resistance, inflammation, stress. So 4 different normal reasons, root causes for PCOS. The way that we're going to review it so that it makes the most sense is we're going to review androgen excess first, insulin resistance second, inflammation third, stress fourth. And that's why I have these little red arrows, right? Okay. However, if we were to look at it like pathologically, what normally starts first, it normally goes the other way around. Normally stress is the initiator, then that promotes inflammation, then that promotes insulin resistance, and then that promotes androgen excess. Okay. I saw someone's hand go up, but I couldn't tell the name. It was like David Gindi. I'm not, David Gindi, do you want to
Hi,
unmute
hi,
yourself and ask the
hi.
question?
Yeah,
Yes.
I just wanted to know what is androgen excess? Maybe I just assumed you were going to get to it soon, but
Oh,
by definition.
boy, are we going to get to it. It's going to be the
Okay.
first thing we discuss. So I'm happy that you're curious because we're going to answer you.
Yeah, sorry that I'm under a boy's name. I thought that scared you off for a minute.
I was a little concerned, but it's like, okay, maybe, I don't
No,
know.
no, no, no. I'm here. I'm a woman.
Okay,
Okay,
thank you.
fine.
You know, sometimes it's a joint account, you never know. Okay, so, all right, so the four root causes: androgen excess, insulin resistance, inflammation, stress. What we're going to do is talk about how each one can contribute to PCOS, and also how to test for it, and also how to treat it. It's going to be really informative for anyone who has PCOS, but it's also going to be tremendously informative for any woman who wants to get to know her hormones more. Okay, so buckle up, let's go. So let's first understand androgen excess. But in order to understand this, we have to first understand what is your normal hormonal cycle? And then also, how do you produce these hormones? Okay, I love this graph because I think most women don't know this information, and it's so pivotal for your understanding of women's health. It's also going to change if you truly understand this graph when you're going to test your hormones. Okay, so you'll see here on the bottom, we have a key. Okay, so the blue line is estrogen as it increases and decreases throughout your cycle. The red line is progesterone. So we see how it's low in the follicular phase and high in the luteal phase. Okay. Now, why is it called follicular phase and why is it called luteal phase? Good question you ask. I'm just going to go back so that you can see. Okay. So when we are striving towards ovulation, we're basically producing and maturing the follicle. So it's called the follicular phase. After ovulation occurs here, there's a luteum that is left over, and that's the let's say the decreasing luteum phase that we're in. So that is why it's called the follicular phase or the luteal phase. Okay. And different things happen during each time because during the follicular phase, the whole goal, the whole purpose is striving for ovulation. And so the hormones are going to adjust in order to mature that follicle. And then whether or not there's conception, the hormones are going to adjust to either take care of what is left over and then get the body primed for menstruation, or obviously if conception happened, then to take care of that embryo. Okay, but let's operate under the assumption that conception has not happened. So what tends to happen is when you receive your flow, when your period begins from day one right here. Okay, so this is under the impression that we're going to have 5 days of flow, right? So what happens is all of our hormones are at their lowest. Okay, estrogen is at its lowest, progesterone is at its lowest, luteinizing hormone is at its lowest, and follicular stimulating hormone, or FSH, is at its lowest. So now I could say this. This is why I get so peeved when doctors only do a blood test on day 2 or 3 of your cycle. For most women, not PCOS women, but for most women, it's not going to show anything exciting because all of your hormones are at their lowest. So basically, it doesn't show if your estrogen gets high enough to successfully ovulate. It doesn't show if your progesterone gets high enough to help you prepare for a healthy menstruation. So that's my little pet peeve. It is an important day to test your hormones, but it really shouldn't be the only day. Okay. If you are someone with PCOS, then you can receive good information. But I'm going to say another really important thing. you cannot draw a line with one dot, nor a conclusion. You need to have 2 test dates, 2 days on your cycle to be able to get any type of impression of how your hormones are functioning. Okay, so now as you depart from your cycle and you lend towards ovulation, your estrogen is supposed to rise. And the estrogen rising is what then helps stimulate luteinizing hormone and follicular stimulating hormone. Okay. That rise of estrogen, once it gets to a certain level, is also able to then help stimulate the growth of progesterone. All of these hormones work in synchronicity with one another to get to, hopefully, a high progesterone state. Okay, does that make sense so far? So I'm just going to say it over again. Day 1 of your period, all of your hormones super low. After that, they all start to climb up. Let's focus on estrogen. Estrogen increases. Women love estrogen. It is what makes us so awesome and so loving and so encompassing. It's what makes civilization excellent, is this estrogen that women are queens of. And so it's so nice when it increases. Everything physiologically is in greater synchronicity when our estrogen is high. Our muscles work better, our brains work better, our appetite is smaller. Everything is fantastic as estrogen increases. Okay. And it increases to a peak around, let's say, day 10 to day 12 of your cycle. This varies a lot individually. It could be day 9 for some women, it could be day 12 for some women, but generally it peaks around this time before ovulation. Okay. And then it starts to dip down a little bit. And that first dip for some women, specifically women with PMDD, could be a little harsh. We could get a little sluggish in that dip. And then there's a subsequent rise. And then it goes down again to its lowest right before menstruation. Okay, so that is the history, the timeline of estrogen. Progesterone, on the other hand, is supposed to be very nice and low for ovulation. Some women can have high progesterone during this phase, and if so, they will not ovulate. So this is another reason why we'd like to test around day 10 to see if estrogen is high enough or if progesterone is getting in the way of ovulation, because that can sometimes happen. Okay, the reason why I point that out is because there's another reason besides PCOS that stops ovulation from occurring. Yes, Tamal, you have a question. Please feel free to unmute yourself.
I just wanted to say you have a bunch of questions in your chat. I think people are sending them. So take a look there, and I think you'll see some questions to address.
Oh, thank you for telling me. Okay, thank you. So the question was, what is PMDD? Which, Ashley, thank you so much for answering that, is premenstrual dysphoric disorder. It's a I would classify it as a psychological disorder that happens during the transitions of your hormones. Women who experience it will have severe depression or severe, almost like a personality disorder, when their hormones shift. So this could be during times where their estrogen plummets. This could be because of insufficient progesterone. It's actually very variable per woman. And so that's why it's important to test on multiple days to see how your cycle is adjusting. For example, this is one case for PMDD, which is that estrogen, as it goes down, drops too fast and too low. So for example, this would be a nice healthy drop for estrogen. Maybe with a woman with PMDD, it drops to this level, which is too low. And so that clear and very sharp difference is what can cause a mood disorder. So much so that during that time, she could be clinically suicidal. But then when her estrogen is either nice or high, or hormones are in more balanced state, she's totally fine. She can't relate to the mood disorder that she experienced earlier. So that's like on one foot, a really nice and basic explanation of PMDD. Okay, so that's one question. If it doesn't pertain to now, I might answer your question later. Okay, answer that already. So anything that has to do with testing, I'm going to answer later on, because there's a whole slide for when to test and what to testing. I might drop little bits of information here and there, but most of the testing information is going to be later on. Another thing that I probably should have said from the beginning is some of this information might not apply to you. Make sure to have a little piece of paper or a pencil near you so that if something does catch your attention and just like, ooh, that really applies to me, make sure to write it down. Okay. So we talked about estrogen and we talked about progesterone. The reason why this is really important to know is because we want to understand which hormones are supposed to be high on which day so that we could then later test for it. I'll give you an example. Someone with PCOS, for example, doesn't have a complete ovulation, right? And she's going to have really high luteinizing hormone. Now, her luteinizing hormone is anyways going to go high because she's trying to ovulate, but it's going to stay high. Okay, it's not going to dip down like it's supposed to. Another thing that's really important to know is that she's not going to have high enough progesterone for many different reasons. Her progesterone is not going to increase. One of them is because of the luteinizing hormone. It's because of the androgen excess. It's because of the low estrogen. For all the many different reasons, her progesterone is going to be low. And so if she does a test, let's say on day 21, and she sees, oh, I have really low progesterone, ooh, that's another clear sign that I have PCOS, and maybe even a specific type of PCOS. And that could even be a very nice clue for her doctor to say, ooh, this person would probably really benefit from a progesterone-style birth control, although birth control is not necessarily the answer for every case of PCOS. But let's say in this example, it might be really helpful or suitable. And by taking a progesterone-based birth control, it's going to drive the luteinizing hormone down. Okay? So now that we kind of have that under our belt and we have that shared information, let's move on to another really important slide. Okay? And once we have this, we could move forward and understand everything that this lecture has available. Okay? Getting really hot in here, so I'm just going to decrease this. There we go. Okay, it's going to be freezer here in a second. Okay, so what I want to go through with you are how hormones are produced. This is important information for any woman to understand. Women with undiagnosed hormonal imbalances, women with PCOS, women that are going to be from age 35 to 45 that are dealing with perimenopause and don't even know it, women with menopause, okay, or in menopause, I should say, or women who are postpartum. Any type of hormonal condition, you should know this information, okay? So let's start here. What we want to discuss is, how do you produce hormones? How do I produce the hormones that I need to take me through this whole ovulation process? So all of your hormones work in a domino effect. One hormone is produced, and then that hormone is used to make another hormone. That is how every hormone is made in the body. Specifically when I'm talking about your gender hormones. Okay, we're just talking about these gender hormones. So again, I'm going to say it works as a domino effect. You make a hormone, you use that hormone to make another gender hormone. You then take that gender hormone, use it to make another gender hormone. It works in a domino effect. And for women, our ultimate goal, our, what's it called? Final destination is estrogen, because estrogen is what makes us amazing. It is what allows us to ovulate. It is what allows us to give life. It is what allows for mankind to benefit from womanhood. Estrogen is queen. So that is where we're trying to get to. And before I move forward, Yehudit, I would love to answer your question.
Oh, it's just a technical thing. It's really hard to see those slides because they're so contracted now. Like I couldn't see the whole slide of your ovulatory pattern, and it was difficult to follow. And this one too looks like a very nice slide. I'd like to see the whole thing.
So happy you told me. Let's change the way that I'm sharing it. We could totally do that. Does that work for you? Yeah, I'm going to take that as a yes because it can't get any bigger, right? Okay. So here we go. So this is the hormone pathway that leads to estrogen. So first we have to understand that all hormones, their beginning, start with your brain. You have a hypothalamus that will communicate to your pituitary gland, and this is the beginning of your hormonal production. The hypothalamus pituitary connection is the beginning. Okay? Anything that could negatively affect your hypothalamus or your pituitary gland, like stress, for example, could then negatively affect the entire production of your hormones. All right? That's key to note. Another thing that's really interesting, and I don't know if this is too much information, but I think it's really fascinating, is that the hormones that your pituitary gland releases produce and release it in pulses. It's not like you're producing a steady flow of, let's say, luteinizing hormone or follicular stimulating hormone. You're producing these hormones in pulses. And I find it to be very fascinating because it's kind of like anything that has to do with the female body is very, very water-based, like a wave going in and then going out. There's more to say about that, but I just find that very fascinating. Okay, so the hypothalamus and pituitary gland are stimulated, which then communicates to the adrenal glands. Now, in the case that you don't know what the adrenal glands are, your adrenal glands are your stress glands that sit right above the kidneys. They are like the little tiny triangular hats that sit on top of your kidneys. They have two major components to them. They are responsible for your fight or flight response. They produce a lot of hormones that we're going to talk about. They also produce cortisol, which is responsible for how you respond to stress. And they also contribute to your electrolyte imbalance and your water balance and how you're able to retain water. It's also really important for your energy production, and then also, again, communication to the kidneys, because they are the little tiny brains of the kidneys, if you'd like to call it like that. Okay, so what happens first? Let's say if this was the first step that we were going to fast forward to, is you produce something called pregnenolone. Now, pregnenolone is the mother of all hormones. It is what you then use. It's the steroid hormone, the first steroid hormone you use that is going to eventually become estrogen. It's something that you could actually take orally as a replacement or as a substitute to hormone replacement therapy. Okay, so we have this mother hormone called pregnenolone. And then pregnenolone has two options, okay? It's either going to make something called DHEA, which is an androgen, or progesterone. All of this is happening in the adrenal glands. So again, all of this is happening in the little tiny triangular hats that are sitting on top of your kidneys. So you produce pregnenolone, and then there's going to be a split. Some of that pregnenolone is going to make another hormone called DHEA, And then some of that pregnenolone is going to be used to make progesterone. So far, are we clear? Yeah. Sarah, I'm looking towards you. So if you nod, then I know I'm making sense.
Okay, I'll nod.
Thank you. Okay. So now let's take the path of DHEA. Okay. Let's say we're going to follow the trajectory and we're going to see where it goes. So DHEA is something that's called an androgen. An androgen, if we wanted to define it very simply, is like a male-based hormone. It's something that is normally very high in men and supposed to be relatively less in women. Okay, we do have great benefits from having a nice supply of DHEA, but we do not want the same amount that men have. Okay. Now, this DHEA could then go to two different places. It could either be used to produce estrogen, or it could be used to produce testosterone. DHEA is an androgen. DHEA is an androgen. It could be used to make another androgen, which is testosterone. Again, it could also be used to create estrogen. Once DHEA produces estrogen, there is no going back. There are no take backsies. Once you produce estrogen, it is estrogen, okay? If you take that DHEA and you produce testosterone, well, isn't it funny? Testosterone could be made into estrogen. And that's what we essentially do with all the testosterone that we produce, is that we take it and produce estrogen, okay? So DHEA could make estrogen in two ways. It could either make it directly, or it could make it indirectly by taking testosterone and converting it into estrogen. Does that make sense? Yeah? Okay, cool. Now, what if we follow this other trajectory? We have pregnenolone, which is this mother hormone. It's the first of all hormones, and it produces progesterone. Again, all of this is happening in the adrenal glands. This is going to be really important information in a little bit. Like, why am I keep repeating that it's in the adrenal glands? Okay, so progesterone is produced. Now, what happens to this progesterone? It's going to make testosterone. And then that testosterone is going to make estrogen. Okay, just to go back 1 second to this. Do you see that as I produce more progesterone, my estrogen is going to start to increase? Ooh, why is that happening? Because when I produced progesterone, some of that went into testosterone, which was then later converted back to estrogen. As my progesterone started decreasing, my estrogen also started decreasing because I have less of what's making my estrogen. Does that make sense? Isn't that cool how it comes together? Okay, I find it fascinating. So you have this testosterone from progesterone, and it's supposed to, if everything is working properly, go into estrogen. And then bada bing, bada boom, you have your key hormone that makes you feel so fantastic, obviously in the right amount. Something that could happen along the way is that this testosterone, instead of going to estrogen, can become DHT. DHT is like an unusable form of testosterone in a sense. And this is what promotes balding in men and women. So like women with PCOS that have androgen excess, for example, can have elevated amounts of DHT. And that is what can cause a lot of the hair thinning on the scalp that sometimes happens, okay? Has what I said so far make sense? Or should I repeat it? Should I just do a summary of it? You know what? Instead of asking, I'm just going to do a summary. Okay, so let's just review this one more time. All roads lead to Rome is an expression. Well, in this case, all roads lead to estrogen. All of the hormones you produce lead to estrogen. That is what we want. We do this by stimulating the hypothalamus, which then stimulates the pituitary glands. Okay? That then travels down communication to our adrenal glands. And our adrenal glands, again, sit right on top of our kidneys. And they produce this beautiful hormone, this mother hormone, the steroid hormone called pregnenolone. And pregnenolone is then going to be what produces all of the remaining hormones. It's either going to produce DHEA, which is an androgen, which is either going to directly convert to estrogen or create testosterone. Or the pregnenolone is going to create progesterone, and then that too can then create testosterone. Anytime you create testosterone, whether it comes from DHEA or progesterone, is supposed to, in women, become estrogen. But through manipulation of an enzyme, it could become DHT instead. And if it becomes DHT instead, now from two major sources that you're supposed to be turning into estrogen, you're not. That's going to create estrogen deficiency or insufficiency and an increase in one specific type of androgen called DHT. Does that make sense so far? Okay. Any questions from anyone? There's no such thing as a stupid question. If you are thinking it, probably someone else in this group is thinking it and would probably receive a lot of benefit from you being courageous and asking.
I would like to ask if you could please repeat
Yes.
what you just explained. I did understand how everything can turn into testosterone and some things do not turn into estrogen at the end, or they do, but I didn't understand the last part where you explained how some sort of enzyme can create, instead of it creating, again, how we got to a point where there is an estrogen deficiency.
Correct. Okay, fantastic. Okay, so I'm just going to summarize what you said that you understand. And I'm not going to get too into it because we are going to eventually get there and it's going to make more sense. But if we were to think of this in like a really basic sense, okay, I have two ways that I could produce testosterone. I could produce it either through DHEA, okay, and that can directly convert into testosterone, or I could do it through progesterone, and that could directly convert into testosterone. If everything is working correctly in the female body, that testosterone is supposed to be directly going into estrogen. But for many different reasons that we will get into, instead of this testosterone going into estrogen, it could go into a subversion of testosterone. This subversion of testosterone is DHT. And this DHT can wreak havoc in both men and women. It's what make men go bald. And there are medications that could actually decrease DHT in men. And so therefore it preserves their hair. But for women, let's say, if I have all this testosterone, and instead of taking this testosterone and converting it to estrogen, if I take that and convert it to DHT, I now have lower levels of estrogen. It's kind of like this. Let's say testosterone is a budget, okay? I have $50 that I could put into either estrogen, which is a party, or DHT, which is school supplies, let's just say, okay? And I take 40 of those dollars and I convert it into DHT. That means I only have $10 left to put into estrogen. So that is essentially what happens when I produce high amounts of DHT. What that means to me is I now have less to make estrogen. And so this is one example of a situation of androgen dominance, where I have an excess amount of this specific androgen, which means as a result that I have less estrogen. Maya, did that make sense? Or was I still unclear?
No, perfect. Thank you.
Okay, fantastic. But I think that that was a really excellent question to ask, because all androgen dominance leads to this one conundrum, which is a lack of estrogen. So We're going to get into the very specifics of it, but I'll just give you some really basic examples now so that you could see what I mean. We could have androgen dominance in the sense of I have elevated amounts of DHEA. And there could be an issue that instead of this DHEA converting to estrogen, it converts to too much testosterone. So I could have high levels of DHEA and high levels of testosterone, and it's too much in comparison to the amount of estrogen that I have. So that's one example of an androgen dominance where I just have too much DHEA going on here. Another form of androgen dominance could be that I have too much testosterone going on. And again, too much of this, although maybe I could make a sufficient amount of estrogen by comparison to everything else, it's just too many androgens. Okay? Does everyone understand how we produce estrogen? Just from the basic, this produces this. Yeah, that was clear? Okay. So now that we understand this part, which is how hormone changes throughout the month, how I can't speak. Let me say that again. Now that we understand how hormones change throughout the month, okay, and now that we understand how hormones produce one another, now we're primed and ready to understand what androgen dominance really is. Okay, so as I said before, there are multiple kinds of androgen dominance. There's one that's called ovarian androgen dominance. So that's very interesting. Let's talk about this. If you notice, different hormones are produced in different places. So DHEA is produced in the adrenal glands. It's not produced in the ovaries. What is produced in the ovaries? Estrogen is produced in the ovaries. Testosterone is produced in the ovaries. But DHEA, progesterone, pregnenolone, not produced in the ovaries. That is produced in the adrenal glands. Okay, fantastic. I just as a side note, I once suggested for someone who was in menopause and didn't want to take hormone replacement therapy, I suggested pregnenolone to her. And like she came back to me and said her doctor didn't want her to take it because it's something for the adrenals and not for her hormones. And I was like, but does he not understand that you take pregnenolone and make it into your hormones? Okay, so we produce the mother hormone in the adrenal glands, but that has communication to the ovaries. And then the ovaries then produce estrogen and testosterone. Why does this matter? Because when I say that there's ovarian androgen dominance, what that basically means is that androgens are being produced in the ovaries. It's an ovarian problem. And it could be produced in the ovaries for a bunch of different reasons. It could be produced in the ovaries because of the elevated amount of luteinizing hormone that is coming from the underdeveloped follicle, right? So it's really just a matter of the follicles are contributing to their own problem. And if the follicles just had a break, if we just decrease that luteinizing hormone, we could stop the androgens from being produced, okay? Whereas there could be adrenal androgen excess, which means that the androgens that are being produced are a result of the adrenal glands being off. So this is very likely a DHEA problem. Okay. Then there's peripheral androgen conversion in fat tissues. So for example, what we see here is testosterone can be produced in your fat tissues. So can estrogen. So if someone is experiencing excess weight for a variety of different reasons, that weight, that extra weight, can actually be the contributing factor to their androgens. Okay, and then the last one that we're going to really talk about in this lecture is insulin-mediated androgen excess. So insulin resistance is the reason why there's excess androgen production, which we'll explain in depth why. If we can test and conclude which form of androgen excess you're experiencing, then we could properly treat you. If we are not testing and we don't know the exact cause of your androgen excess, then there's no way we could possibly treat you correctly. Because if we look at this and we say, okay, PCOS has a cure. How can I cure it if I don't know what the cause is? So why am I going into such depth is because it's so easy to figure out the cause if you know why and how, and you need to understand what is the pathology of all these different situations so that you could figure out what's your specific why. Why is this happening for me? Please, Adina, you had a question.
Yeah, can you hear me?
Mm-hmm.
Okay, I don't know if this is something we're going to get to or not, but I was just curious when you were saying about that excess fat tissue can cause the problem. What about not enough fat tissue? Could that also, does that have any?
It's a great question. It's a great question because a lot of women with PCOS are stigmatized to be overweight, but that's not necessarily the case at all. Not every PCOS condition is generated by either insulin resistance or excess weight. So it's just that what I'm trying to stress from the peripheral androgen conversion is that that could be one of the contributing factors of androgen excess, but that's not to say that just because you don't have excess fat that you are not going to have a different situation of androgen excess. So you could be really thin and still have androgen excess. Does that make sense? You could also be very overweight and have androgen excess, but the reasons for every person with androgen excess could be different. They could be multiple. You could be experiencing only one of these, or you could be experiencing multiple of these. Yes, Yehudit.
Okay, regarding the obesity or overweight issue, like what comes first? Does obesity cause the difficulty in the hormonal, balance, or does the hormonal imbalance cause the obesity or insulin resistance in all cases? I just always wondered about what came first and what it's really attributed to.
It's such a good question. And I think that we have to treat it individually. Like you're a practitioner, right? You're an excellent acupuncturist. Shout out to Yehudit if anyone is there and would like treatment. But I think we have to treat this individually because we don't want to make assumptions. I think that's the most important part. We don't want to make assumptions. If someone has both of them, they have excess weight and they have insulin resistance, then I think it's safe to assume that most likely the insulin resistance could be causing the excess weight. However, there are many cases of it being the opposite. So I think that's why it's really important to do a very thorough intake, to see the history of the person, to do very important blood tests. For example, if you could see a history of someone's blood over the course of a few years, which is really nice when someone has like a medical portal, and you could see blood work from many, many years ago, you could see, okay, this person was overweight back in 2011, and yet they didn't have any signs of a blood sugar imbalance or insulin resistance. So I think you have to treat it very individually as a practitioner or as a person who's advocating for themselves. You look at your history and you see. Okay. Oh, and then last is that there could be a genetic predisposition, there could be a genetic predisposition for having higher androgens. There are so many different genetic conditions that can contribute to this. And again, this is why testing is really, really important. But that's not something that I could address in this lecture. Okay, so Sarah, you also had a hand up. Please, I'd be happy to answer your question.
Thank you. So when we're testing, one of the things that they test for is a DHEA. So they're testing for an excess of that as a possibility to diagnose PCOS.
Right. So you want to make sure, and we're going to cover this in the testing section, you want to make sure that DHEA is something that is being tested for regardless of what your situation is. Because I'm going to say this again, you could have androgen excess and not have PCOS. It could still be contributing to a lot of the uncomfortable feelings that you could be feeling monthly, but it's not necessarily disrupting your ability to ovulate. Let's just say that could happen. So why did I say that? Because it's important, regardless of your hormonal condition, that DHEA be something that is included in your hormonal testing panel. But it's imperative that it be tested in order to rule out PCOS, and what kind. Okay.
Thank you.
Let's just, of course. So let's just review again. And also these slides are going to be available to you. I'm going to send out an email and you guys are going to have a recording of this lecture and you're going to have the slides. So I know that I wrote like a little mini textbook here, but you guys could read it on your own time. So again, there's ovarian androgen excess. Okay, the ovaries are the part that's responsible for producing the excess androgens, like in this case, testosterone. It could be driven by insulin resistance. It could be driven by the high luteinizing hormone. And then the luteinizing hormone overstimulates the ovaries, and then that contributes to an even greater increase in androgen production. So it's like a problem that contributes to the problem. You don't have successful ovulation, that immature follicle is producing more and more luteinizing hormone, so to speak, and that, or creating more production of luteinizing hormone, and then that luteinizing hormone is creating more androgen production. So the fact that there's this underdeveloped follicle is just contributing more and more to the problem. And then people with this specific kind, oh, I drew something and I don't know how. Okay, so people with this specific kind of androgen excess will have excess facial hair and body hair, acne, scalp thinning, etc., which you will see in any type of androgen excess condition. Okay, then there's adrenal androgen excess. This is produced not from high testosterone in the ovaries, but high DHEA. Okay, this could be a response to stress, because the adrenal glands are what really is being affected here, and the adrenal glands are your stress glands. Okay. Then there's, again, peripheral androgen conversion. So you have peripheral tissues like fat tissues, and they produce weaker forms of androgens. And then, so there's a specific enzyme that we were talking about before, particularly 5-alpha reductase, and this is responsible for converting testosterone into DHT. So when you have excess peripheral tissues, it could increase the amount of testosterone that is then produced, that then leads into DHT. So that decreases estrogen production, because that testosterone, instead of going up into estrogen, is going to DHT. So that's an example of how just weight can decrease the amount of estrogen that you produce, because instead of the testosterone going into estrogen, it's going into DHT. There's an interesting, weird thing that could happen. Again, so you have these peripheral tissues, excess fat. You could actually create estrogen dominance in the same way. You have this fat tissue, you create testosterone, but for whatever reason, you're able to make that conversion from testosterone to estrogen. So increased weight could either create an estrogen deficiency or it could create an estrogen dominance, depending on whether there's going to be that enzyme present. Isn't that interesting? I think it's so fascinating. Okay. And then there's insulin-mediated androgen excess. So insulin resistance drives androgen excess. There are many different reasons why this happens, and we're going to go more in depth as to how that occurs. But again, figuring out what your situation is imperative for creating the right treatment program. Okay. Any questions before I move on to insulin resistance? Just unmute yourself. I'm very happy to answer questions.
I have another question, if that's okay.
Please, Sarah. Yeah.
So in the menstrual cycle, and you might have gone over this, and I apologize if I missed it. So you, from my understanding is that you sort of have weaker follicles, and then you have this dominant follicle, and then as that grows stronger, it recruits kind of more estrogen from the brain. And then once that gets big, once that becomes, I don't know, a certain size or whatever in your menstrual cycle, that kind of recruits the LH to cause the LH surge for ovulation. But that was my understanding, but it sounds like what you're saying is that somehow you have all of these kind of subpar, follicles that are kind of not really growing to any kind of dominance. Right. And then somehow that is starting promoting the LH, is recruiting LH, or how?
It's the immature. So LH is supposed to increase.
Mhm.
LH is supposed to increase. That luteinizing hormone is supposed to increase. Ovulation occurs at this peak phase when luteinizing hormone is at its highest.
Mhm.
And then when the egg releases, there's no need for that luteinizing hormone. So when the egg is released,
Mhm.
there's a feedback loop.
Mhm.
And the brain and the ovary gets a certain response that says, ooh, ovulation was successful.
Mhm.
So now luteinizing hormone could go down.
Mhm.
Like we did what we came here to do.
Mhm.
But if there's no ovulation,
Mhm.
then luteinizing hormone just keeps going
Right.
up because it's like trying to get this thing going, but
Mhm.
it's not happening.
Mhm.
But the problem with increasing luteinizing hormone even more and more and more is it actually drives androgen production up.
Mhm.
So there's no turn off that's saying luteinizing hormone, okay, just be quiet. It just keeps going up. And then you have multiple immature follicles. And again, they are going to now produce testosterone.
Got
And
it.
now that testosterone could either maybe be converted to estrogen or it could convert to DHT,
Mhm.
which is another androgen. And then
Mhm.
that's going to cause more problems. But all of this is leading to a situation that is not going to produce enough progesterone
Mhm.
and is not going to therefore produce enough estrogen later on. So it creates a depression of all the female-based hormones like estrogen, progesterone.
Right. Right. Thank you.
Does
Yeah.
that make sense?
Yeah. Thank you.
I think your question was really necessary. I don't think I explained it properly, and I think that really clarified it for everyone. Okay.
Can I ask a question?
Please.
At what age in a child do we say maybe we should look out for the PCOS part?
Ooh, that's such a good question. Let's look at the symptoms. Okay. Ooh, here we go. So it's very, very normal for a girl's cycle to not be in alignment for the first 3 to 5 years of her life. Like that's fairly normal for it to be inconsistent and off and light and heavy and all these different things. So the irregularity of her periods, we don't look at, we don't consider because that's really normal for that age group. But things like excess hair growth, like if she has hair on her chin or on her, or like, or really long sideburns, for example, if she has severe acne, if she has thinning hair, like she just doesn't have a thick head of hair, but everyone in the family might, or maybe there's another person who doesn't and they also have hormonal issues. Or maybe like you see how they eat and you're like, they shouldn't really be this heavy, but they are. And then maybe you do a blood test and you see like, oh, you know, her blood sugar tends to be high or her triglycerides tend to be high or something like that. Then those are all signs that could be like, I think maybe we should look into this. But again, it's really, really normal that for the first 3-5 years of a woman's life, her hormones are not regular. So that shouldn't be the verifying factor. Like I
What
should be.
about the period not coming in at all? At what age is that a concern?
Like she hasn't gotten it yet.
Yeah.
I think after the age of 16, I would look into it. I think until 16, I wouldn't really look into it. And the reason why I say that is because I think that we're just getting our period earlier and earlier and earlier. Like I think now girls are getting it at age 10. I know that when I was growing up, it was around age 12. I know that in my mother's generation, it was between 12 and 15. So I think we're just getting it earlier. So it's not necessarily a concern if someone's getting it later. Not necessarily. There are a lot of things that you could do to help your daughter who hasn't got her period to support really great hormonal health, but I just wouldn't like pay attention to it too much.
Thank you.
Yeah, and the reason why I say it is because I'm always nervous. It's such a huge part of a woman's it's a big time where a woman shifts her perspective on life. If she all of a sudden becomes too overly concerned with her body, it could create a lot of stress and anxiety later on, and it might not be even worth that anxiety. And that's why I'm just more cautious and say it's not worth to look at.
Thank you.
Of course. Okay, so let's talk about insulin resistance. Let's first understand what insulin resistance means. Okay, so basically what happens is anytime you eat something, whether it's an apple, can you guys see me, even a little box of me, or do you guys just see the screen?
We see in a little box.
Little box. Okay, fine. So anytime you eat anything, it doesn't matter if it's a protein, a fat, a carbohydrate, it doesn't matter if it's 50 calories or 100 calories or 300 calories, anytime you eat something, you are going to secrete insulin, okay? If it's just protein, right? If it's just fat, does not matter. You are going to produce insulin. And the role of this insulin is to take energy from the food that you've consumed that's circulating in your bloodstream and absorb it into the cell. So that's kind of like this picture that we have right here. You have glucose and it wants to get into the cell. Okay, you see these little yellow balls? Their whole goal is, ooh, I want to feed the cell. But they can't just go in, right? Like this is the club. The little glucose balls want to go into the club, but they can't just go in. They have to prove themselves. There needs to be someone who opens the door for them. And that's what insulin does. Insulin is like the little bouncer that opens the door for the glucose molecules to come in and party. Okay? Without insulin, they can't go in. So insulin is a really key factor to keep health, I can't speak, to keep cells nourished. Okay? Now, what happens with insulin resistance is that the receptor in which the insulin binds to becomes like insensitive to insulin's approach. A really good example of this is like, let's say if you have really loud kids and they're screaming and shouting all the time, after a while, you just become less aware of it. You're just like, oh, this volume is just my normal, and I'm going to adjust my attention and my hearing and everything to this volume. Okay, so that's basically what happens the more and more glucose and sugar you have in your body over time. You have so much sugar that these receptors become adapted to how much sugar you're normally getting and become less receptive to insulin's effect. And so because insulin can't really bind to the cell like it used to, it's bringing less sugar in. And that's why some people will experience hypoglycemia, like low blood sugar, before they become hyperglycemic, which is then high blood sugar, because of this insulin sensitivity. Okay? What happens is that the more insensitive this receptor becomes to insulin's effect, the more insulin you produce. So again, imagine these loud kids, right? They have a certain volume and you're just so used to their noise that when they're shouting at you, you don't really pay attention to it. So they have to shout even louder in order to get your attention. So the pancreas will then again produce more and more insulin to then try to get this glucose into the cell. And what happens is this insulin that you overproduce will have a profound effect on the ovaries and the specific cells in the ovaries. So it's not necessarily just the blood sugar that's an issue that causes inflammation and etc. It's the direct effect of the insulin on the specific cells of the ovaries. So what is that participation? You have something called theca cells. And theca cells are cells in the ovaries, and what their job is to do is produce testosterone. Okay? And so what happens is these high insulin levels, the insulin will actually have an interaction with the receptors of these theca cells. And it'll almost be like it's artificially saying, hey, ovary, produce more testosterone. But that's an issue because it's already an under-ovulated cell. So it's kind of like I have increased amount of luteinizing hormone and I have insulin, working its magic on these theca cells, and it's producing more and more androgens. And that's one way insulin resistance will cause androgen dominance. So what comes first? Two things. It could be that the insulin resistance is driving androgen dominance. That could be the majority of the whole scenario. Or it could be that there was already this predisposition for androgen dominance, and then the insulin sensitivity made it worse, or the insulin resistance, I should say. Okay? Does that make sense? Isn't it interesting how a problem could then become a bigger problem? You just want to stop it from being a problem, but you can't because it's like, feels like it's out of your control. Okay. Another thing that insulin does is it decreases something called sex hormone binding globulin, which is another really excellent test to run when you're trying to see if someone has PCOS. Because if someone has insulin resistance and that is driving their PCOS, their SHBG, or their sex hormone binding globulin, is going to be driven down. And they're going to have low levels of SHBG. And what that does, essentially, why that actually matters for us, is because SHBG is a binding protein. It's supposed to bind to excess amounts of androgens and make them unusable. But if insulin is driving this binding protein down, then all the androgens that we have are going to become dominant. They're going to be usable. And we don't want that because we want estrogen to be our driving force. Okay, so then that again contributes to symptoms like acne and balding and facial hair growth and irregular periods. Okay. Also, insulin resistance will disrupt FSH, follicular stimulating hormone, which is then the thing that we produce in our pituitary gland that is responsible for ovulation. So it just completely slashes the whole ovulation process. Okay, so these are the key reasons how insulin sensitivity can further create androgen excess or further disrupt ovulation. Any questions on this so far? We're good? Fantastic. Now we're going to go to inflammation. I think that androgen excess and insulin resistance go really hand to hand. I think one leads to the other. I think insulin resistance for many people, for many women with PCOS, will contribute to androgen excess. But I think inflammation is like a completely different ballgame. And a different group of women will have this. And it's really, really important that it's understood, because if you treat someone that has inflammation and that's their primary cause as someone who's insulin resistant, they're not necessarily going to receive the treatment that you want. They're not going to necessarily be cured. Yes, Ashley, please, what's your question?
Hi, so my question is, a long time ago, one of my doctors tried treating my PCOS with metformin. And my understanding is that's like an insulin type issue. It's supposed to treat the insulin issue, and the metformin did absolutely nothing compared with the other medications that I took at that time or before that time. Does that mean that my PCOS was not related to any insulin issue?
It could be. It's hard to know without looking at your blood work, because you could easily say metformin just wasn't the best medication for your insulin resistance. You could always say that. There are many different types of insulin resistance medication, and you could easily say, you know what, that one was just not suitable for you. That is a possibility. Or you could say insulin sensitivity was not the cause of your androgen excess. And so that's why it didn't work for you. That is a very plausible conclusion. And again, that's why testing is so important, because if you're not testing insulin, if you're not testing your blood sugar, if you're not testing all these different things that we test for throughout your cycle, then there's no way of ruling that out. But what tends to happen, and this is why I created this lecture, is women come in, their doctor just labels them with PCOS for a variety of different reasons, and they just give them either birth control that is not necessarily the right one for them, or they just give them metformin, and then it's kind of like they're left as those are their only options, and they're definitely not their only options. So I can't conclude if it's not insulin sensitive or insulin resistance or not. It's too little information for me to give you a conclusion, but it's a plausible conclusion.
Thanks.
Of course. Okay. So let's talk about inflammation. So inflammation can come from a variety of different ways, but let's just like narrow it down to 3 different ways. There's immune activation. So there could be inflammation that occurs due to an infection, an injury, or some type of harmful substance. And this will cause reaction in your cytokine production, which is what you produce when you're having an immune response. Or there could be chronic inflammation that is persistent inflammation driven by excess body fat. Or it could be from poor gut health, like leaky gut or colitis or Crohn's or something like that. This affects women in so many different ways. And I think it's so important to mention, because if this is the core cause of your PCOS, then not addressing this won't lead to a permanent solution. So you could, let's say, have androgen dominance. This could very well be something that's happening to you, but it's only as a result of this. And if this was taken care of, then the androgen dominance won't keep perpetuating. So you still have to treat the androgen dominance. You still have to bring those androgens down in the ways that we're going to suggest. But this as a core problem needs to be addressed. Okay, so let's talk about how that happens. So there could be chronic low-grade inflammation that happens from excess body fat. So there's someone who is really overweight, and that could happen for so many different reasons. It could be because they're eating in a way that's just not suitable for them, or it could be that they have a genetic disposition to have excess weight. There are many different variables here. No one should make any assumptions as to why they're overweight, but let's just say that they have excess weight. That could participate in the chronic low-grade inflammation that they're experiencing, which then could be what is participating in their PCOS. Okay. Now, I want to go back to this slide for a second, and I don't think I correctly wrote this down, but I think that there are a lot of women who have a histamine intolerance, that they know that they have a histamine intolerance. What is a histamine intolerance? A histamine intolerance is that you react differently to certain types of foods that either manipulate the enzymes that have to do with your histamines, or they have the histamines in them themselves. And your body could have a natural intolerance to these foods. And a lot of women don't realize that they actually have this intolerance. And having this intolerance creates a lot of chronic inflammation. So they would be almost in this state where their immune system is chronically activated. They have this constant release of cytokines, and they don't even know it. We're going to talk about it. I'm going to give a solution for that. I'm going to discuss it. But that could be one of the reasons why someone could have androgen production, because they have this inflammatory cytokine release, and it's producing the androgens in their ovaries. Okay. So again, there could be low-grade inflammation that's just coming from fat. Okay. There could be inflammatory cytokines that stimulate the ovaries that could either be from a histamine intolerance that comes from a whole category of allergies. It could come from eating excess amounts of dairy for some women, but typically this is food-based, meaning you're eating something, you're consuming something that doesn't agree with you, and it's creating inflammation. And then that inflammation in and of itself is what's causing the insulin sensitivity. So you see, it's like what was asked earlier, like what comes first? It's like the chicken or the egg. Well, remember when I said, like, we're going to look at the 4 root causes this way because it'll be the easiest way to understand it. But really, if we wanted to look at what comes first, it's normally the other way. So a lot of inflammation in the body could then create insulin sensitivity, and then that promotes an issue upward. Okay. So that's the way inflammation can cause PCOS. Again, it could either be something that happens from too much fat for a variety of different reasons, excess fat, which causes inflammation in a low grade way. It could be that you're eating something that is causing either high or low grade inflammation, or you have really poor gut health, and the inflammation in your digestive system is causing that increase in inflammation. So again, this would be someone with leaky gut. This would be someone with Crohn's or colitis, and they don't even know it, or even celiac, right? There are a lot of people with celiac that don't even know that they have it. So that is the contributing factor there. And then let's just talk about stress. Okay, so how does stress cause PCOS? So stress is a very interesting factor. So if we go back, just going to go back to this picture for a second. Where does stress affect us in the body? Stress affects us in this whole axis. This is called the HPA axis, where we have a hypothalamus, H, pituitary, P, and then adrenal glands, A. And the HPA axis is really what cycles and is in control of all of our hormone production, and in short form, our thyroid health, our adrenal health, our energy, our concentration, our focus. The HPA axis contributes to all of that. So where does stress affect us? Stress affects us along this entire pathway. So the pituitary gland, which is in large responsible for producing luteinizing hormone and follicular stimulating hormone, if we're experiencing any type of pituitary stress, like lack of sleep, too much caffeine, stressful situations, etc., this pituitary output is going to be depressed, or it's going to be insensitive to the feedback loop, or a variety of different things. The adrenal glands are what produce a lot of our hormones. If the adrenal glands are stressed, we could hyperproduce DHEA. We could hyperproduce progesterone, which again can all convert to testosterone. So just looking at that visually, this whole stream, the hypothalamus, pituitary, adrenal glands, this is the part of our body that is most affected by stress. And when we are negatively affected by stress, right, because there's positive stress, there could be stress that is exciting, right? That's one way of translating stress. But then there's also stress that could be scary and threatening. And when we experience that stress for a variety of different reasons, that excess amount of cortisol production, or the influence that has on our FSH or LH, could then create adrenal excess, and then also disrupt ovulation, etc. So this is a key factor, and I think what is the beginning step of everything else. Also, stress worsens inflammation because of it increases the amount of cytokines that we produce when we're inflamed, and also worsens insulin resistance. But my key focus on stress is, again, how it affects the HPA axis. Any questions so far? No? Okay, so let's just do a quick summary before we talk about practical long-term solutions. There are 4 things that could happen when someone has PCOS. And what is really PCOS? It's really just unsuccessful ovulation that happens consistently. And then that unsuccessful ovulation then creates a negative feedback loop with the rest of the hormones that just perpetuate the process. But there are many different reasons why that could be happening. That could be happening because of androgen excess. And as we learned, there are different kinds of androgen excess. That androgen excess could be happening because of insulin sensitivity, okay? Or it could be happening because of a skew in the adrenal glands, or in the ovaries themselves, or in the fat tissue. And anytime you have stress in any one of those organs, it's going to perpetuate the problem. So like a really common example of this, dairy. Okay, so dairy is known to be a not beneficial food for hormones. Why? Because within many dairy products, there's a sugar called lactose. Lactose is a two-part sugar made of 1 part glucose and 1 part galactose. Galactose is known to increase inflammation in the ovaries. Okay, not in every woman, but in a nice percentage of women. So if you're one of those women that has inflammation, ding, 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 in your ovaries, that is going to create or potentially create androgen excess. Okay, so these root causes, androgen excess, insulin sensitivity, inflammation, and stress, it could sometimes be that someone is experiencing multiple root causes, not just one. But again, when you do the correct type of testing and you try to be thorough and say, okay, what could potentially be the culprit here? You have to look at all 4 sides of this specific spectrum. And if you're not looking at all 4 sides of the specific spectrum, then you're perhaps missing the opportunity to have the correct treatment. Does that make sense? Okay, so now let's talk about long-term solutions. So I'm going to break this up into 2 sections. I understand that the people who are going to hear this lecture are not my normal clients. So I don't know specifically what's happening to you individually. I don't know what your specific cause is. So I kind of feel nervous giving very, very specific suggestions, like you should wake up and eat this and drink this and do this. That's not going to work because I don't know what your whole map is. That doesn't make sense. So what I'm going to do is I'm going to go through, this is what I would suggest in this scenario. This is what I would suggest in this scenario. This is what I would suggest in this scenario, etc. And I'm going to do that in 2 parts. I'm going to do that with supplements and I'm going to do that with food. Okay, does that make sense? And I'm going to give you my 2 cents because some things might be more appropriate for others. Okay, so I should have gone to the slide first. Okay, but which root cause are we addressing? We don't know which one to address first. We'll have to do proper blood tests for that. But let's start with insulin resistance first. Okay, so insulin resistance has many different avenues of treatment. The first suggestion that I would recommend for anyone with PCOS, any person with PCOS, is to take inositol. Okay, inositol is almost like a pseudo B vitamin that mimics insulin and supports ovulation, and it also reduces androgens. There are 2 kinds of inositol. There's myo-inositol, and then there's chiro-inositol. And generally, we like an inositol that has both of them together. There's great benefit to taking both of them. They do different things. So if you just take myo-inositol, great, but better to find one that has both of them together. And normally what you'll see available is like a ratio of 2,000 milligrams of myo-inositol to 50 milligrams of chiro-inositol. And that's excellent. And you could take, there are really no negative side effects of taking it. So you could take 2 grams of it a day, you could take 4 grams of it a day, you could take 6 grams of it a day. I wouldn't recommend taking more than that. Okay. Now, berberine is another excellent herb that's fantastic for the immune system, fantastic for inflammation, and also really fantastic for insulin sensitivity. Just as a side note, for some people, it could make your tummy a little icky. it could either create diarrhea or acid reflux or just an upset stomach. So if that's something that happens to you, maybe berberine is not your ultimate solution, but it's a really good solution for people who have insulin sensitivity or insulin resistance, excuse me. I always say the opposite. Okay. Now, cinnamon, alpha lipoic acid, chromium, those are typically something that you could find together in a blood sugar support supplement. So you don't have to take them individually. You can even find it with berberine nowadays. Those are all, again, really good for reducing blood sugar, improving insensitivity, making the receptors of the cells more sensitive to insulin. But it should be noted that taking a supplement or an herb that helps with insulin sensitivity, but not changing your diet is like not helpful. This should be taken in conjunction with the diet because the diet is essentially what caused the problem in the first place. So this is a solution, but if you don't treat the original problem, it's not really going to get you far. Okay. Now, fenugreek is a fantastic herb for blood sugar issues, for insulin sensitivity, for high blood sugar, for low blood sugar. So it helps the insulin resistance that causes hypoglycemia, and it helps the insulin resistance that causes hyperglycemia. My favorite way to take it is actually not in supplement form, but to create a mother tincture from it, or a mother essence, where you take the seeds of the fenugreek and you boil it in water. So you take, let's say, 1 tablespoon of fenugreek seeds and you boil it in 2 cups of warm water for, let's say, 5 minutes. You let it brew, you let it cool down, and you drink that every day. It's also something that really helps decrease inflammation in the body. So it's working not only on insulin resistance, but also on chronic inflammation. You should just be aware that it could make you a little stinky. This could happen because it really works on your lymphatic system. That's why it makes your breast milk all great. But because it works on your lymphatic system, it makes all the yucky stuff come out. And the residue of the fenugreek will also come out from your lymphatic system. So you'll actually smell it on your clothes. Some people say that it smells like maple syrup. It's never smelled like maple syrup on me. Like, it normally makes me smell like a gross old man. But you know what? It's so good for you that it's like worth it to smell like a gross old man. And you just tell your husband to also eat it. So like you're both smelling like old gross men, and then it really doesn't matter. So I highly recommend it. I also want to suggest that alpha lipoic acid is an excellent supplement to take if you have high triglycerides. Like, if that's the component of your insulin sensitivity or insulin resistance, if that's present there, then alpha lipoic acid is definitely your jam. It will help you. And something you should know about alpha lipoic acid is sometimes you could get a rash from it. So I highly recommend taking biotin when you take alpha lipoic acid. It can help decrease any type of side effects that could come from it. So those are the supplements for insulin resistance. Again, I'm giving this advice not knowing any of your information, but by and large, this is what's generally recommended. You have to take it multiple times a day for it to have impact. Taking it once a day, you're not going to see anything. Taking it with 2 meals or 3 meals is an excellent choice. And consistency leads to results. So taking it for 1 week, not going to do anything, because we're working on hormones, and hormones have a lifespan. And anytime you're trying to make changes with your hormones, you should expect to see changes not a week from now, but a month from now. So whatever you're implementing or you're initiating, just be consistent with it for a month to 2 months before you assess whether this is helping you or not helping you. Okay. There was something else that I wanted to say about insulin resistance. One thing that I want to say is I'm very pro medication. I have no problem with someone taking medication for their insulin resistance. You shouldn't think that the medication is a cop-out for changing your lifestyle and your habits, specifically because a lot of these, like Ozempic, for example, or a lot of these new GLP medications can have negative effects if you don't address your lifestyle. Like you could have significant muscle loss, etc. But I'm very pro medication. I'm very pro someone taking their health in their hands and saying, I need to do something. This is what I have the strength to do. This is what's going to help me, etc. Because let's face it, there are a group of women who have done it all, done the natural, bent over backwards, and did not get results. And so there's really no shame in taking medication. But we also know that medication is not always the answer. For example, many people who take these GLP medications, when they stop taking it, their insulin resistance returns, right? So what do you do then? So I think that these supplements, these herbs are really good additions to a daily practice of self-care that you will see the results with a few weeks, a few months from now. Okay, now let's talk about androgen dominance. I have a really big list for androgen dominance because there are many different reasons why someone could have androgen dominance. So again, inositol is a really great supplement for any reason with PCOS, reduces insulin, improves insulin sensitivity, helps reduce androgen levels. Okay. Again, myo-inositol, D-chiro-inositol or chiro-D-inositol. It's a good 2,000 milligram to 50 milligram ratio, taken multiple times a day. Other things that are really excellent are spearmint tea. Spearmint is fantastic for decreasing testosterone. Decreasing testosterone from the ovaries, decreasing testosterone from fat cells. I highly recommend that anyone who feels like they have excess weight and that might be contributing to their androgen levels to just religiously drink spearmint tea. Okay. There are some studies I think that show that this tea is actually more effective than the tincture, but I could be wrong. I might be incorrectly remembering. So that's something that I really advocate for. Zinc is excellent for androgen dominance, specifically to help lower DHT. So when you have DHEA that's creating a lot of testosterone and progesterone that's creating a lot of testosterone, and instead of that going into estrogen, it's going into DHT. So zinc is really fantastic for taking that. And again, once a day, not enough. Taking multiple times a day, very useful. You don't want to overdose it. You know, zinc is a mineral. You can overdose it. The correct amount to take, I can't tell you because I don't know your specific situation, but you could easily take 15 milligrams or 25 and then take that twice a day and feel like that's a very safe amount to take. Now, this is another thing that I'm going to say that's going to be funny, is taking prostate formulas are excellent for androgen dominance. Because what is a prostate formula by and large? It's something that helps decrease DHT. So if it's useful for men to decrease DHT, it's also going to be really wonderful for women to decrease DHT. And I feel like there isn't a nice packaged product for women to decrease their DHT. So most of it comes in the packaging of prostate health. So no, you do not have a prostate. I'm not confusing you for a man, but I highly suggest that you get a really good quality prostate formula that has saw palmetto and nettles. And that would be really excellent for decreasing your DHT and also any type of androgen excess. Okay. So like an example of this DHT business, sometimes people are taking birth control because their doctor said, hey, this birth control is going to be really good for a lot of this androgen dominance, but they're not actually seeing results. Like they still have thinning hair, they still have the facial hair on their face. Maybe it's less, but it's not fully fixed. Then taking this saw palmetto nettle compound prostate formula, however you find it, will really, really help with that, those symptoms. Licorice is really fantastic for elevated DHEA and testosterone. Reishi, really fantastic for any type of androgen dominance. It's a mushroom. Omega-3 fatty acids, excellent, excellent, excellent for decreasing the production of DHT, making sure that you have proper conversion from testosterone to estrogen. And then NAC or N-acetylcysteine also really helps lower testosterone. It supports insulin sensitivity, also really great for decreasing inflammation. Okay. And those are the supplements that I generally suggest for androgen dominance. I know what you're probably thinking. You're like, what if I have both? Does that mean I'm supposed to take this and this? Like, are you expecting me to like just support the entire supplement industry myself and take 20 supplements a day? No, that is not what I'm going to suggest to you. I will tell you how I would actually implement this, but first I'm just going through the list. Okay. Now that we've maybe like lowered our stress, let's talk about inflammation. So inflammation is a little tricky because it depends where you're inflamed. Or is it that your ovaries are inflamed? Is it that your digestive system is inflamed? Like, what's the part here that's inflamed? So depending on the part that's inflamed, we're going to take different supplements. So let's say we have general inflammation. We have inflammation that's either coming from like histamine intolerance or because of the ovaries, okay? So in that case, omega-3 fatty acids are excellent. Turmeric, excellent. Ginger, excellent. A lot of times you could find those three together. Like there's a really fantastic product that's not always available, but it's by a company called California Gold. And it's a fish oil that has a lot of really fantastic anti-inflammatories. It's called curcumin up. And it has curcumin, which is the extract from turmeric. It has ginger, it has black seed oil, it has baswila. And what else does it have in it that I can't remember? It's a whole bunch of anti-inflammatories, and that's a really excellent one for inflammation in the ovaries or inflammation from histamine intolerance. But in addition to that, like we said before, NAC or N-acetylcysteine is really good at decreasing inflammation. Vitamin D, not having enough vitamin D can really increase inflammation. So making sure that your values are above 40, between 40 to 60 is really key. And if you're not taking enough vitamin D, you're also not going to increase your values. So it's really imperative that when you take vitamin D supplementation, you're taking at least 5,000 IU. Because for many people, if you're taking under that amount, you're simply not going to absorb it. So it could be that when you take 5,000 IU of vitamin D, what you're really only getting from it is 1,000. But if you were to take 1,000, you wouldn't take any in at all. Does that make sense? So it's always better to take a higher dose and cycle it rather than take a low dose consistently. So like 5,000 IU of vitamin D every day for 3 months, take a 3-month break. 3 months on, 3 months off. That's like a really good system for vitamin D. Magnesium. I didn't mention this before. I put magnesium down in every slide. There are different kinds of magnesium. You specifically want magnesium glycinate. There are many different benefits from all the different forms of magnesium, but if you want a magnesium that's going to help decrease inflammation, help build your female health and not negatively affect your digestive system, then I highly recommend taking magnesium glycinate, either magnesium glycinate or magnesium bisglycinate. If you're taking magnesium citrate, for example, to improve your digestive system, it might not necessarily be absorbed enough to then affect the inflammation. So you could take multiple types of magnesium at the same time, depending on what your goal is. Okay? Baswila is frankincense. Frankincense is really fantastic, both if you're experiencing a histamine type of inflammation, an ovarian type of inflammation, or even a digestive type of inflammation that could come from colitis, Crohn's, or leaky gut. Okay. Oh, wait, wrong one. And then there's serrapeptase. Serrapeptase is really good for breaking down the inflammation that's present. That's for any situation. Quercetin, resveratrol, excellent for any situation. If you specifically have digestive inflammation, this is what I would consistently take. Glutamine, probiotics. What kind of probiotics? That's a whole different workshop. Slippery elm, aloe vera. So again, depending on the kind of inflammation you have, like let's say you're like, oh, I have PCOS and oh, I also have IBS. I should be taking the supplements for digestive inflammation. Okay. And then for stress, why would you take supplements for stress? Because you could technically be taking the supplements for androgen dominance, which is being caused by your stress. Okay. But let's say, for example, if you have the type of stress that is causing adrenal androgen excess, then taking these types of herbs would be very crucial. Okay. So there's a whole bunch of them. I'm going to tell you what my favorites are. I love ashwagandha. I think it's a very beautiful herb that helps stabilize and harmonize the adrenal glands. It doesn't have very many side effects. And it's also really easy to tell when you don't need it anymore. When you've taken enough ashwagandha that you're like, oh, I'm good, you normally tend to become really thirsty. So if you take ashwagandha and religiously and all of a sudden you become really thirsty, that's like your body saying, oh, I don't need any more ashwagandha. Okay. Really fantastic at decreasing androgen dominance, really fantastic at decreasing cortisol, really fantastic at just nourishing and rebalancing the adrenal glands as a whole. Okay. There are other herbs that are equally excellent. Okay. Magnesium is also really good. B vitamins are really good. My next favorite are licorice and relora. Licorice is excellent because it works both on the androgens and it works on the adrenal glands. So it's like multifaceted. And then relora comes from the magnolia flower and the bark. And it's so fantastic for decreasing cortisol, which can be a perpetuator for inflammation and for androgen excess. Here's the deal with taking stress supplements. Sometimes they're more appropriate during the start of the day. Sometimes they're more appropriate during midday to later in the day. So anytime you take a supplement that lowers cortisol production, I normally recommend taking it mid to late day. So ashwagandha, no earlier than 1 p.m. Licorice root or relora, probably better. Well, not licorice root, but relora, not sooner than 1 p.m. After 1 p.m. Because otherwise it's going to drop your cortisol down too much and you don't want that. Okay. And here are some more herbs that you could take to help regulate either the HPA axis, the pituitary gland, or the adrenals. Okay. So my suggestion for the supplements. You're going to figure out what your root cause is. And then once you figure out what your root cause is, you're going to be able to go into the section, the appropriate section, and choose which ones I should take. I don't recommend taking more than 4 or 5 supplements at a time. Sometimes I do, as a practitioner, I will recommend a client take 6, 7, 8 supplements. But that's because I'm her expert. I know what's her situation and I'm watching her back. If you're doing this on your own, please do not take more than 4 or 5 at a time. Remember that consistency leads to results. Most likely the dose that they're suggesting is not enough to see clinical results. And again, you see the evidence of your success a month to 2 months later. So you're not expecting to see anything now. Another important thing in regards to supplements is introduce them to your body one at a time. Don't take 5 supplements for the first time all at once for a few different reasons. It's a lot for your body to adjust to. And secondly, if God forbid you have a weird allergic reaction to one of them, you're not going to know which one is causing it. Like my famous story, I had a client, she was allergic to vitamin D. Never would I have ever thought that she would have been allergic to vitamin D. So if she had taken that with all the other supplements, I would have easily thought that it was something else. So you always introduce one supplement at a time. I know we're going like way over time, so I'm going to quickly wrap it up. But for the 22 of you that are still here, I so appreciate your patience. Okay. So now let's talk about food. So food is interesting. I'm not going to give you the conventional answer. I'm going to give you the thorough answer that you deserve. Okay. There are a few diets that help with PCOS. And what you want to do is match the right diet with the right timing of when you eat. Okay. So the 5 diets that we tend to recommend for PCOS are the following: the GAPS diet, an antihistamine diet, keto, high carb plant-based diet, funny that that's for PCOS, or a high protein, low carb, low fat diet. Why are there so many different kinds of diets? Because it depends on what the cause of the PCOS is. And also, every person's insulin resistance is going to be treated differently. So let's go through the first one. The digestive tract is always treated first. Always, always, always. You do not do anything before you treat the digestive system. So let's say if I have a client and she has androgen dominance, but she also has a digestive disorder, I always treat the digestive disorder first, because most likely that decrease in inflammation that comes from treating the digestive tract will make treating the androgen dominance so much more manageable and so much easier and so much faster. So digestive is always first. So because, again, I don't know your specific situations and I'm giving this this lecture to a wide audience, I think a really fantastic place to start for anyone who's trying to treat leaky gut or a really severe inflammatory digestive disorder is the GAPS diet. You could easily Google what it is. It's a very specific type of elimination diet that focuses on bone broth, on very easy to digest food, introducing things at a very specific time. There are ways of adjusting it depending on what your dietary restrictions are. But this would be something that I would highly recommend as a way to reduce gut inflammation that is perpetuating the PCOS problem. Okay, an antihistamine diet. If anyone is really curious about an antihistamine diet, you could totally Google it. There's a lot of information available. You could also reach out to me personally. I'd be happy to send it your way. It focuses on very specific foods and, most importantly, avoiding specific foods. Some examples could be bananas, chocolate, fermented foods like vinegars, even healthy things like fermented, unfiltered apple cider vinegar. There are certain foods that for some people can really increase histamine response. So if you are in that category, just the inflammation alone could be the contributing factor to your PCOS. And if you do everything else besides follow this key diet, it's just never going to fully be treated. That's not the case for every woman. It's a small subset of women, but that subset of women deserve to have a treatment plan. And so that's what that is. Okay. Then we're talking about insulin resistance. So I'm going to say something that you're not going to hear very often from most people. And I wouldn't be surprised if this is going to be like another fad. Okay. I like to think of this as a triangle where you have 3 different kinds of macronutrients. Okay. So you have fat as a macronutrient, you have protein as a macronutrient, and you have carbs as a macronutrient. And there are different types of people for a variety of different reasons, and their insulin sensitivity can be triggered from any one of those macronutrients. So we normally think that insulin resistance is caused by too much sugar. That's what we normally think. Insulin resistance is caused by too much sugar, but that is not the case for a lot of people. Insulin resistance could be caused from too much fat. Insulin resistance could be caused from too much protein. Insulin resistance could be caused from too much carbohydrates. It just depends on the person. So there are 3 different types of macronutrient diets that could solve insulin resistance for different women. And the only way that you could really determine it is either if you work with a practitioner such as myself who could determine it for you, or experiment and try. And it's wonderful to experiment because it allows for you to discover a really cool side of yourself. So what is the keto diet? The keto diet is a high fat, low carb diet. It's high fat, minimal protein or calculated protein and low fat. Okay. Or low carb, excuse me. So you're supposed to eat majority of fat, and then you're not allowed to eat more than 20 grams of carbs. And if you eat more than 20 grams of carbs, then you're not really going into ketosis. Now, you don't have to be 100% on this to get benefit, but you're not going to get the benefit of ketosis if you're not under 20 grams of carbs and if you are not measuring the amount of protein you're consuming. I am not such a fan of the keto diet. I think that it serves a very small group of people. It's very excellent for anyone who has any type of neurological disorder like Tourette's, really severe depression in many cases. Any type of neurological disorder, keto could be your jam. But for many instances with insulin sensitivity or insulin resistance, it's not necessarily a true fix. There are many people who follow this diet, think that it's going to be their answer, don't lose any weight, don't see any results in their blood sugar. So the reason why I'm saying that is because don't worry, there are other options. If this didn't work for you, it just means it wasn't right for your body type, and that's okay. So what's another option? This is a very funny option. This is very counter to what a lot of people might think is actually really good for insulin. But it's an 80-10-10 diet. It's actually really good for anyone who's type 1 diabetic. But anytime you have any type of insulin resistance, this could be really, really helpful. High carb, low fat. What do I mean by low fat? Like you're actually not having any amount of oil, like not a drop of olive oil, not a drop of sesame seed oil. You could have nuts, you could have seeds, but it shouldn't exceed 10% of your total consumption. And people who do this diet, not everyone, because it doesn't work for everyone, like I would really suffer if I did this because it does not agree with my body at all. And I tried for many years to force myself into this because I did not have enough self-kindness to be like, hey girl, this is not your thing. But for many people, this could completely fix their insulin resistance. And it's funny because it's high carb. It's really, really high carb. Doesn't matter. This could be their solution. Again, it's not the majority of people, it's a group, but this group deserves to be served. And that's why I'm sharing this information. Okay.
So when you talk about carbs from like, you mean like potatoes and like more starch?
Potatoes.
Okay.
Yeah, it could be potatoes. It could even be grains.
Okay.
It could be bread. It could be legumes, anything that would naturally have any type of gram of sugar. And then that would be the majority of their energy intake. Now, there could be negative side effects from taking it. Like you might not be consuming enough fat to then improve your estrogen production. Like you might have still some type of estrogen deficiency from this diet. However, insulin resistance could be totally taken care of. Okay. And then my favorite option, which I think affects most people relatively well, is a high protein, low carb, low fat diet. It doesn't mean no fat. It doesn't mean no carb. It's just lower than the protein consumption. So like, just as like, if I was to shout out numbers here, it would probably be something like, let's say, making sure that you're hitting like 30 grams of protein per meal or 20 grams of protein per meal. But that you're making sure that you're really hitting that mark and that you're not forgetting to have a moderate amount of carbohydrates and a moderate amount of fat. Like you're not exceeding those values. If you make sure that you hit a lot of protein, but you're also eating a lot of carbohydrates, and a lot of fat, you're not improving your insulin resistance. You could be getting benefit from that protein that could be making changes in your physiology that could be like have a nice effect, but it's not necessarily affecting the insulin resistance. Because what is key here is that these macronutrients work in proportion to one another. Why is why is keto effective? Because the carbohydrates are so negligible. Because the carbohydrates are so negligible, the fats that you are consuming are now usable. So when the macronutrients get shifted in ratio, they become either usable or not usable. And so it's the ratio of the macronutrients that really matter more than just eating a bunch of one. Does that make sense? Okay.
Haley,
Yes, please.
For this one, the high protein, would tofu be acceptable since it's a phytoestrogen? Any problems with that?
Such a great question. I have mixed feelings about soy because I think a lot of people have an intolerance to it and they don't know it, but not the majority of people, but some people do. And it's also like everywhere. So it could be that people are just getting so much of it in so many different places. But let's say if you don't eat an ultra processed diet, having tofu as your source of protein in regards to PCOS, I think is perfectly fine. If you have other hormonal issues, that might not be the case. Like if you have estrogen dominance, not a good food choice to use. But in the case of PCOS, I have no problem with it whatsoever. Yeah, good question. Okay, so now there's one more bit of information that needs to be addressed, and that is food timing. So food timing is like this. There are 2 rules. And I'm not going to go so into the science of it because I know that we're like way over time. But the premise is based on your circadian rhythms, when you're supposed to eat, when you're not supposed to eat, when metabolic hormones work in conjunction with other metabolic hormones. So here are the rules. If you are following a diet, but you're not necessarily following your food timing, you're not going to improve the insulin resistance. You also have to follow the food timing. And what that means is you're eating every 3 to 4 hours. You're not eating sooner, you're not eating later. That's key. Because if you're a nosher, meaning you're just consistently eating, then you're always stimulating your insulin. And if you're always stimulating your insulin, that's just going to drive up your insulin resistance. What you need is to have a rest period between meals. And if you don't have that rest period, you have no insulin break. And that's what we're really after, because we want the noise to come down so that the receptors can be more receptive and less resistant. So having a gap between 3 to 4 hours is really helpful. You could have insulin resistance and still be hypoglycemic. So this might be a really big challenge for you. And this is where B vitamins could be really helpful. Also, it's not all or nothing. As someone who used to have hypoglycemia, I know that waiting 3 hours was a real big struggle, but I knew how important it was. So I went 2 hours, eating every 2 hours and 15 minutes. And once that became comfortable, eating every 2 hours and 30 minutes. And then once that became comfortable, eating every 2 hours and 45 minutes until I now comfortably could go long periods of time without eating. Okay, now just because I said that we want a rest doesn't mean that we want too much rest. If you exceed 4 hours, you could potentially over-secrete insulin the next time you eat, and then again, participate in that insulin resistance. So having a really steady rhythm of meal expectancy, eating every 3 to 4 hours, doesn't have to be the same time all the time, but having that rhythm is really, really key to working on that insulin. And then Adina, before I answer your question, the second rule has to do with something that we know is called intermittent fasting. So intermittent fasting is really simple. It's based on the fact that we have a day and night cycle. We're not supposed to be metabolizing food way into the night. So our metabolism does not operate like we're supposed to be eating during nighttime. And that's how it really works. So what we know is that we have to have a minimum of 12 hours of resting between dinner to the next day's breakfast in order to have that metabolic effect of intermittent fasting. Sometimes it's better to wait longer, and sometimes it's better to wait shorter. So when is it better to have a 12-hour fast, and when is it better to have a 16-hour fast? If you are someone that has any type of adrenal stress, fasting more than 12 hours is going to be counterproductive. It's going to make your insulin resistance worse. It's going to be making losing weight or excess body fat worse. Do not do it. Okay? And also, it's important to note that you get benefit as long as you're waiting the 12 hours. So if you're someone who has a really difficult time waiting, like it's a personal struggle for you, don't worry about it. Do the 12 hours. That's the minimum that you need to do to get any type of metabolic benefit from intermittent fasting. You don't get all the benefits that happen with fasting, but that's not what we're after anyways. Okay, we just want to work on our insulin resistance. Now, if you don't have any type of adrenal stress whatsoever, then you could safely wait more than 16 hours. Or sorry, not more than 16 hours, up to 16 hours. And it won't have any negative consequences, and it might work towards your favor. Do you have to? No, only if you want to, but don't feel forced to do that. What else is really important to discuss here? I think waiting every 3 to 4 hours and having a minimum of 12 hours between dinner and breakfast is something that any woman can strive to do safely and will have such a huge impact on her insulin resistance and is marvelous in conjunction to the right diet for her. Okay, Adina, you had a question. I'm so happy to answer it.
Yeah, you mentioned a few times, I want to say hypoglycemic. I think that's what you said, which
yeah,
like you're saying that, like, and can you explain what that a little bit? Like, what does that?
Oh, sure, of course. So what is hypoglycemia? Hypoglycemia is when your blood sugar is really, really low. Okay. So let's say, for example, if you were to do a blood test and you measured your fasting glucose, this would be in the 70s, the 60s. Basically, you don't have enough circulating blood sugar to feed your cells. Now, this could be a sign of insulin resistance. Just because your blood sugar is low doesn't necessarily mean that your cells are receptive to that sugar, or that the receptors are not resistant to insulin. And that's where sometimes you could have in blood tests, you could have really low fasting blood sugar and really high triglycerides. Because what's essentially happened is you've taken your sugar, and instead of it going into the cells like they're supposed to, they've been converted to fat, to the lipids in your blood. So that's an example of how someone could have insulin resistance and have hypoglycemia. Okay, that's just one example. But some people have hypoglycemia, and that is that their blood sugar drops and they could feel things like dizzy or weak, or they just have like an increased appetite. They feel like they have to eat every 2 hours, and if they don't, then they just don't feel well. So that's the basic result or symptom of hypoglycemia, but it's as a result of having too little circulating sugar in your blood. And then hyperglycemia is the opposite. It's when you have too much sugar in your blood, and that is a very clear sign of having insulin resistance. Okay, yeah. Of course. Okay. So obviously we have to put all of this together. I know that I gave you so much information, and we just want to know, okay, what do I do here? So I kind of feel like this lecture was about moving backwards. Let's understand the whole situation backwards, moving up until I leave this lecture and I'm like, okay, now I know what I'm doing. So what are we doing? Again, like I said, you don't have X-ray vision. I don't have X-ray vision. Your doctors definitely do not have X-ray vision. We don't know what's going on unless we test. So I want to go through some of the tests that we should do in order to clearly understand what your hormonal situation is like. If you've attended this workshop, okay, I'm only offering it to those who attended this workshop. If you attended this workshop and you do the blood test that I suggest, send it to me. Would be so happy to review it. Be happy to give you quick answers as to what to look for. My pleasure, okay? But if you don't do the test, or I can't do that for you, okay? What nice incentive. Okay, so additionally to a blood test, you should also do an ultrasound, because again, you could have high androgens and still have successful ovulation. You could have high androgens and not have PCOS. It could happen. So it's important to know what you're dealing with, and you can't know what you're dealing with unless you don't lift up the hood and check. Okay, so what tests should you do? So let's go through this. These are the regular tests that you should do at least once a year, okay? Once a year, this should be like your routine. Let's check, let's see how I'm doing. A lipid panel, which is going to test your cholesterol and your triglycerides, your fasting glucose, your hemoglobin A1C. All of this is really necessary in order to see what your insulin resistance picture is like. Not necessarily adequate enough, but a really good picture, okay? CBC is just a general blood cell count, vitamin D, B12, ferritin. Just as like an aside, having chronically low ferritin could be a sign of chronic inflammation. You might not know where it's coming from. It could be from the digestive tract. It could be from an infection that's happening from an IUD that might be present. It could be from a histamine intolerance, but you should just know that chronically low ferritin is a sign of chronic inflammation. And then so important to test your thyroid. So making sure that you test your TSH, please remember this, making sure that it's between 1.5 to 2. Your TSH should be 1.5 to 2. If it's higher than 3, if it's higher than 3.5, if it's in the 4s, you have a thyroid imbalance. And then everything that I've just said has been completely pointless, because there is no way you could heal a hormonal imbalance if your thyroid is not in check. So then it's like the very obvious first step is to treat your thyroid. Now, depending on where you live and what medical system you're a part of, I highly suggest that you test or go out of your way to test free T3 and free T4. If you feel like you have a hormonal imbalance or something is going on, go out of your way to measure this. So like in America, for example, this is an easy test to get. Okay, if you're in Israel, where I am right now, then you have to test, oddly, your TSH has to be abnormal or out of range for them to then cover a free T3 or free T4 test. And that's just inaccurate. You could have perfectly in range TSH and have low free T3 and free T4, which just is a sign that you're not producing enough thyroid hormone, and then your ovaries are not getting properly stimulated to then actually have successful ovulation. Okay, so that needs to be treated, and it could be treated naturally. It doesn't have to be treated with medication, but it needs to be treated, or else nothing else is going to happen. Okay, liver enzymes, making sure that fatty liver is not a part of this picture, and morning cortisol, because your morning cortisol could just show you what's up with your adrenal glands. Okay, is your cortisol too low? You're having adrenal insufficiency. Is your cortisol too high? That's all really useful information in the large picture here. And then the last bit are the hormone tests. So hormones, as we've discovered, they fluctuate all the time. So the days in which you take them matter. I recommend these 3 specific dates. Day 2 to 3, when things are technically supposed to be low. But if your androgens are high on that day, very clear sign PCOS is happening, okay? Then around day 10, so it could be around day 9, it could be day 10, it could be 11, it could be 12. That's all fine. there's a lot of things that we can glean from that. Is your estrogen going high enough for ovulation? Is your estrogen high or is your progesterone high? Is there a switch there? You're also supposed to have a testosterone or androgen bump at that time. So I wouldn't really look at your DHEA and free testosterone at that time. That's probably better tested around day 2, day 21. But it's still a really useful time to see how's your estrogen, how's your progesterone, how are you ovulating with your FSH, what about the LH? That's a really useful time to measure those. And then day 21, a lot of really useful information. How's your estrogen recovering in the luteal phase? Is your progesterone high enough? Because in PCOS, it will not be. Also, when women hit perimenopause, their progesterone in their luteal phase will go down, and that really inhibits sex drive. It really can cause poor mental health, etc. So these are the different days in which I would test. And once more, if you know that you have a hormonal imbalance, do not settle for one test date. Insist on 2 test dates. So whether it's day 2 and 3 and day 21 or day 10 and day 21, I do not care. You have to have at least 2 test dates to have any type of conclusion as to what is going on. Now, when you do the hormone test, you could use that time to do the regular test. And then the second time you do a test, just do just the hormones, right? If you've already done the regular test that year, then fantastic. Just do the hormonal tests. Okay. So now what are the action steps? Okay. You're going to do hormonal testing. Okay. So you're leaving this lecture, you're leaving this workshop, you're going to do these 5 things. First, step number 1, testing. I don't know anything about myself unless I've tested. Fantastic. Once I have my test results and I have kind of an idea of myself and the test results, I'm going to choose the right diet for me, whether that's gut healing, inflammation, reduction, insulin resistance management, whatever one of those you're going to choose of the 5 that I suggested, you're going to choose it and you're going to implement it. And you're going to see how it makes you feel, if it feels right for you, if it's energizing. And then you're going to start your supplement protocol. You're going to choose 4 or 5 supplements, depending on what your test results were like, and you're going to introduce them one at a time. And then you're going to find some way to measure your progress. You're going to set a way to track progress because like having an objective way to measure is what is going to give you the strength to be consistent. And then the very, very last bit is you're going to try to find a way to get support. You're either going to do it with a friend or you're going to go to a practitioner and get coaching or actual guidance, like professional guidance. Or you could join a new group that I'm launching called the Nourished Women Circle. It's my baby that I've been growing for the last 6 months and I'm really, really excited about. So after the Chagim, we are launching an online group focused on women's wellness. It's called the Nourished Women Circle, and it treats 5 different types of hormonal imbalances, undiagnosed hormonal imbalances, which we will help you diagnose, PCOS, perimenopause, menopause, and postpartum imbalances. And so the cool thing about this group is even though it's an online group that allows for you to have access to courses that are shorter than this one, but informative. So even though it's going to have access to group support, to coaching, and to all these wonderful courses about hormones, you'll be able to get everything personalized for you. So depending on what your hormonal plan, your hormonal problem is, will help you determine what it is, what would be the best, most specific approach for you, and we'll give you weekly resources for that. So a weekly meal plan, prep calendar, a shopping list, so that you don't have to have any decision fatigue and thinking, okay, I have this problem, I know what my solution is, but like, how do I actually implement it? So I'm really excited to tell you more about it. It's going to be launching after the Chagim, after the Jewish holidays, and I'll send out more information about it to anyone who has signed up. So that is the lecture. I hope that it was informative. I am now open to questions. I just want to applaud all of you guys who have listened to up until this point. I know it was a really long lecture. I wanted to give you all the information and all the resources so that you could be empowered and you could be feeling capable that you could take your health into your own hands and actually order your doctor around. Okay, the floor is open to questions. Ashley, you had a question, your hand was raised. Or Rachel, sorry.
I'm just clapping. Good job, Eva.
Yay to all of us.
Super
Yay.
informative.
I have a question.
Yay.
I have a question. Hi.
Please.
First of all, thank you so much. It was so informative
My pleasure, Yehudi.
and very clear. Thank you. So being a trainer, I'm interested to hear what you feel about the exercise side of PCOS. Because I know there's a lot of different guidelines.
You are so amazing for asking that question. Okay, so PCOS is a lot of different things. It's an inflammatory condition. It's a condition that needs the adrenal glands to be well rested in order to recover, regardless of the situation. And it's normally a condition that is perpetuated by stress. So normally people who have PCOS, I would not recommend cardio. I would not recommend elevating heart rate. I would recommend exercise, but I wouldn't be in the zone that you are perpetuating stress or increasing cortisol. Now, there could be two different extremes here, okay? So anyone who has PCOS will benefit from exercising. And what that means is participating in movement. And that movement could be walking, it could be dancing, it could be head, shoulders, knees, and toes, it could be Tai Chi. Any kind of movement is going to help with the treatment of PCOS. It helps with insulin resistance, it helps decrease inflammation by circulating lymphatic fluid. It's beneficial. Okay. It's also beneficial to work on your muscles because your muscles can then help with insulin resistance. So weight training is totally fine for PCOS as long as you are not overdoing it. Now, there could be the type of weight training that you work until fatigue, like you work until you can't work the muscle anymore. And I think that might be fine, but I wouldn't focus on that. I would treat the PCOS first. And while you're treating the PCOS, participate in movements that are low heart rate and participate in weight training, but that's not pushing the heart rate too high. So I think that would be my answer.
So when you when I hear guidelines of things like cardio no more than 1 hour, where do these rules come from? No more than 1 hour. I mean, if you're doing consistent, low impact workout where you're not causing too much stress on the heart, where does this 1 hour rule come in? And also I've heard different ideas about whether to do weight training before you do the cardio, whether to do the cardio, like when the whens and the timings. And I'm not sure, like I've always been very confused about it.
So I want you to personally email me afterwards because there's someone that I want to connect you to that I think would be really, really informative for you. But okay, here's the thing. If you are going to be someone who exercises for more than 1 hour at a time, then there's no way around it. You're going to have to treat your adrenal glands. They're going to need the recovery. And if you don't take like the adrenal herbs that I recommended in one of the slides, then it's going to stress out the adrenal glands, and that's going to create a host of problems. So you could technically exercise for longer. You're just going to have to pay attention to your adrenal glands if you do that. Okay. If someone had insulin sensitivity, sorry, insulin resistance and was walking for an hour and a half, that's not the same as if they were running for an hour and a half. Even if you're an athlete and you could run for an hour and a half at 120, 130 heartbeats per minute, it's not the same. So I think that where this information is coming from is a really good question. I think it's coming from a few different things. I think it's coming from male-driven research. And I think there's going to be a lot more research that is female specific, because what we're learning now from the research that is coming out is that women, how they recover from exercise, how their body reacts to exercise is actually very different than men. And there's a lot of research that's coming out to show that. And so what we do see from research when it comes to exercise in women is that they are way more susceptible to the stress of the exercise. And so they need to have the chance to recover from it. And so that could be that you could be a super duper athlete and spend a long time exercising, but you need to address the adrenal glands. I feel like you had another question that I wanted to answer. Also, another thing that I would say is it depends on what you're doing for the length of time. Are you doing cardio for that length of time, or are you doing muscle building exercises for that length of time? Because also the type of exercise that you're doing is going to control how much time you should be allocating. So I think, long story short, I don't know how to 100% answer you, but for your own practice, I'm happy to connect you to someone who I think could answer a lot of your questions. Are there any other questions, Rachel?
Yep, I changed my mind. So you mentioned if you have a thyroid issue, you need to take it first. So I just found out I have Hashimoto's, so I need to get that under control before doing these steps.
So yeah, so if you have Hashimoto's, which is an inflammatory condition, you do want to treat the thyroid first. Okay, so that means being on the right supplement protocol, being on an anti-inflammatory diet, maybe perhaps being on medication, depending on what the results of your tests were. Okay. Depending on that treatment plan and your other test results, you might be able to work on anything else that's hormone related. Okay. Like you could work on the pituitary gland that then affects all of your other hormones. You could at the same time decrease androgens. It really just depends on how that fits into the entire treatment protocol. You could say to yourself, wow, everything that I'm doing for the thyroid is like taking up so much of my time and attention and concentration. I can't think of adding another thing. That's really fair. But you could also add other things that are going to address the hormones. You just can't address the hormones if you don't address the thyroid.
Sure.
So definitely thyroid first, and then either in conjunction or afterwards, you can work on your hormones. Depends on how overwhelmed you feel.
Right. Any comment on why Kaiser as a whole has the TSH test so much higher than what is would be truly recommended to be a thyroid problem?
What is their reference range?
4. If you're above 4, then they
yeah, most TSH tests will vary, but normally the reference range is around 5. It could even be around 5.5, even almost close to 6. It really depends on the lab, the bureaucratic setting, so to speak. So what I find is the more bureaucratic the lab, the higher the TSH is going to be, or the less likely they're going to let you do a free T3 or free T4 test. But what I would say is reference ranges as a whole are very outdated. So when it comes to cholesterol, when it comes to hormone tests, like for example, this is a common issue that I see when I see my patient's blood work and I look at their DHEA, the window could be anywhere from 1 to 11, let's say. but that reference range is including men and women. So they could have a high DHA of, let's say, 4 or 5, but they think that they're normal because they're basing it off of the reference range. But that reference range was suitable also for a male, and it's perfectly fine if their DHEA is like 8, right? So I wouldn't necessarily go by a reference range. When it comes to TSH, we want it to be in that narrow window of 1.5 to 2. If it starts creeping above 3, then it's a sign that there might be something going on with the thyroid. If it consistently goes lower than 1, then we know that the adrenal glands are really stressed out. A lot of people think that it's a sign of hyperthyroid. It's not. It's a sign of stressed adrenals. And what did I want to say? Something really, really important that left my brain. Hold on. Ooh, brain constipation. I cannot remember. It'll come to me.
Yeah. Thank you.
Okay. Ashley, you had a question.
Hi, yeah. So I know you said that the first 3 to 5 years of a person's life, like, like you can't tell anything yet, but is there any way to prevent PCOS? Because I know that it runs in my family, and like, I don't know if it's too early to kind of be cautious for my 1-year-old. Like, I don't want her to have to suffer the way I did, or the way, any of us did. I mean, like, is anything gonna like ruin her, or is anything gonna like save her at this point?
What a loving mother. Okay. I hear the question. I really think that until puberty sets itself in, there's really nothing you can do. And it could be that that's the wrong answer.
Okay, so like, don't worry about.
I don't think so. I think now we don't have any research to suggest that there's something that you can do. There's a huge trigger that happens once those hormones surge. Okay. And I don't think that anything you do beforehand could really help that, except for like making sure that she doesn't have insulin resistance, like eating like a normal diet, exercising for like a kid, right? Like 11-year-old, 12-year-old, eating a normal diet, exercising, all of that stuff, I think is really important. I do have one suspicion that one of the reasons why we have so many hormonal imbalances nowadays versus maybe in previous days is because of the huge introduction of plastics. And there's a few things that a person can do about that, like limiting the amount of plastics in their life. But I don't know if that's going to specifically affect PCOS. Maybe other hormonal imbalances.
Well, it couldn't hurt. I mean,
well, it definitely doesn't hurt, because the amount of plastics in our society is like ludicrous, and it gets the like BPAs in a lot of the packaged products really are endocrine disruptors, and we know that they are way beyond what is a healthful limit. So that's the only thing that I would be mindful of, but I can't guarantee that that's going to prevent PCOS in someone who's genetically predisposed for it.
And kind of a follow-up question. So because it runs in my family, like, if it runs in your family, is it the same type of PCOS, or it could be completely different? Like, one is insulin and the other one is like inflammation, like with a daughter or a sister.
It's such a good question. And I don't think I know the exact answer for that, but I'm inclined to say that if the majority of women have PCOS, most likely they're getting it from the same cause.
Okay.
That's an inclination. I'm inclined to say that, but I can't say that with 100% certainty. I would just be surprised.
All right, thank
if there
you.
wasn't like a link there.
Okay, thanks.
Of course. Any other questions? I am so grateful that you guys have spent the last 2+ hours with me. I know that it was a very long session. My hope is that you're walking away extremely informed, that you understand how to look at your own situation and move forward. And if there was something that was not clear, or you want more particular individual guidance, as a functional nutritionist, I'm really happy to make myself available. You could either send me a quick question or schedule an appointment with me, or stay tuned for the Women's Circle that's going to be launching after the Jewish holidays. So if anyone wants to excuse themselves and go, I invite you to, but I will stay as long as there are questions. So Ashley, you had a question?
Hi. Yeah, I have another question. So, how likely is it that the type of PCOS can change in somebody's lifetime? Like, is it possible that, somebody had like an inflammatory caused PCOS and, 10 years later has like stress caused, or I recognize that, you can have more than one and maybe like one dominates the other at a different time, but like, let's say it's like 90%, or how likely is it that it's like 90%, one type, and then, 5-10 years later, it's another type?
A really good question. This is going to be my answer that I don't know if it's going to satisfy you, but it's going to be the most accurate. PCOS is a persistent problem that can be treated and cured, but most of the time is stalled. Most of the time, someone has PCOS and is given birth control. And basically what that does is it can decrease a lot of the symptoms of the PCOS, but the actual cause of the PCOS is still floating underneath the surface and is just kind of like waiting to be activated. So what we know also about PCOS is that it perpetuates itself. It could create more and more problems that contribute to the PCOS. I am inclined to say that most of the time when PCOS fluctuates, it just never really went away. It was just stalled. So my question, like I'm hearing your question and I'm thinking, why would the PCOS have come and then gone and then come back? And the only time it really does that is if it wasn't properly treated in the first place, but was just stalled. Okay.
Okay.
And then I'm also inclined to say that if PCOS started in the first place, it was because of a very specific disposition. I don't think it normally comes because, like, let's say, for example, I don't think that someone who has PCOS from poor gut health, once they really treat their gut health problems, are going to have PCOS for another different reason. I think it could happen, but I just think it's unlikely because it's the imbalance that a person experiences at their core that then creates a lot of other imbalances. If you've figured out what the core problem is, then most likely all the other imbalances are not going to happen. And people tend to have like a major weakness where they were born with a physical weakness that when their life is out of balance for whatever reason, that's the part of themselves that gets hit. So I don't think it wobbles that way. Like it was once this and then it was that. I think it was probably one cause that was probably not treated correctly or was stalled. And then now that circumstances of life are different, that has resurfaced and is perpetuating problems.
That's good to hear. If I can just tell you what I did, it was at least 10 years ago, I cut gluten out and it was like a game changer. And since then, there have been almost zero symptoms of PCOS. And so I guess that means it was like an inflammatory issue.
Totally. Totally. Okay. Such a great example of an inflammatory cause. 100%. So then it could be like, let's say if you're getting more symptoms of PCOS, it could be that there are other inflammatory issues at hand. And that might be something that maybe worth addressing it could be that focusing on, again, the herbs that decrease androgen might help you, might help decrease the symptoms and help stop perpetuating the problems, but that might not be the root cause. And so figuring that out is going to be what serves you most.
Okay. Yeah, I haven't had any other like crazy PCOS symptoms since
Oh,
then.
so
I was
you were
just
like
wondering
curious,
if
like
it was
if it could come back.
possible. Yeah, I was just worried if it, you know, anything like that.
Yeah.
But yeah, it took a long time, I think, for the gluten, like, I mean, it took way longer than a month or two for the gluten, from the time I cut out gluten to the time, like, I mean, it was like years and years, and like it just got better and better and better.
So I think that depends on what your treatment approach was. Like if you just cut out the gluten and did nothing else, it would take a long time because the condition of the PCOS has been created, right? So you still have these follicles that are immature, that again are creating creating a condition of high luteinizing hormone and creating a condition where they're producing androgens. It's just that the cause is stopped, but the situation that's there is still there. So again, it's still wonderful to treat the high androgens. That's still a wonderful thing to do. But again, it might not have been the root cause. So if you just treated the high androgens, then you would be in a perpetual cycle of just treating them. But because you took out the inflammation, what was causing the inflammation, you took out the root cause. And that is what allowed for it to eventually go away. So normally I would recommend for someone, if they have androgen excess, to treat it, because it'll just quicken your recovery time and make it more pleasant for you. But you were completely successful and such a great example of someone who removed the inflammatory core of their situation. Yeah. Korakavod, Ashley. I'm so happy. Thank God.
Thank you. Also, all the women in my family have reported that once they got pregnant and had a kid, they're like, everything got better and everything is fixed. 100%. And I found like I had that too, like my skin, it's like no more acne. Like, I mean, not like you know, none, but like a million times better than before. And I thought like, wow, having a kid is really helpful for PCOS.
It's not the case with every person with PCOS. It's not. It is the case for women, many women who suffered as children with PCOS can have that outcome, but PCOS could also happen later in life from, again, insulin resistance. Where that happens normally is when there's androgen dominance. And the reason why it gets rectified is because there's such a huge surge of estrogen that it helps decrease that feedback loop that happens where there isn't enough estrogen, there isn't enough progesterone, the luteinizing hormone keeps going up, and then the androgens keep going up. But once luteinizing hormones go down and estrogen and progesterone rise, it kind of takes that person out of the cycle. And then if they, again, treat themselves accordingly, they won't go back into that cycle, and then they could be out of it.
I'm a little confused. Aren't all the 4 types of PCOS causes androgen dominance? Like, don't they all lead mean that you have an excess of androgen? Let me be
clear about this. Is there a situation that is not androgen dominance? Yeah, all PCOS will. It's like never say all or never. I'm just trying. I can't right now think of a PCOS that won't result in androgen dominance. But not all androgen dominance will be PCOS. But the androgen dominance could be a symptom of a core problem. It's not the cause always.
Oh.
That's why we looked at, remember, like for you, the inflammation wasn't the cause. It was a symptom of the cause, which for you was inflammation, but it kept perpetuating the problem because that's what happens with PCOS. Once that cycle happens, it gets worse and worse and worse and worse. and becomes harder to fix. So like, if I was to share again, let me go back to this and
Yeah, I think I remember one of your slides was about insulin resistance, and then you had a different one talking about the
This one.
androgen dominance. So those
Right.
two are different.
These problems could perpetuate one another, right? So you had inflammation,
Yeah.
and that perpetuated the androgen excess. Okay. But it doesn't mean that the androgen excess was the root cause of your problem. So it could be a byproduct of what happens, but it's not necessarily
Okay.
the core problem.
Okay.
Does that make sense?
Yeah, definitely.
Okay. Are there any last questions? All right, you guys. I wish you a wonderful rest of your day wherever you are. And thank you so much for spending this time with me. I really appreciate it. Bye, you guys. Bye, Ima.